Hello? Oh, no, wake me up. Jeez. Okay. No. Good morning.
Good morning.
Oh my God. I have some good news for you. No PowerPoint. I'm the PowerPoint. Are you ready? Okay. Let's try this again. Good morning.
Morning.
Bonjour.
Bonjour.
Okay, so good. Some of you. Buenos dias.
Buenos dias.
Calamera. That's only for language, I don't know. My name is Dr. George Grant. I am known as the caring doctor because people don't care how much you know until they know how much you care. I have 7,000 clients all over the world. My field of expertise is integrative medicine, anti-aging, and among other things, biofeedback and stress management. I'm not going to list all of my 7 degrees. You can list all of this. Check it out on my website, academyofwellness.com. Write this down as they have forgot to put this on the bio here. They only put my email, and they did not put my website, academyofwellness.com, under my page there, okay? Because this is where you're going to get my 2 published papers on the things that I'm going to talk about now, and also my only 150 other paper, research published paper, evidence-based in my career. I just turned 65 last month. I know I look 65, but we're a little less than that. But it's fine. That's right. So it's how young you feel is not how old you feel. So, in fact, this is my 10th book, How to Live till 101 Healthy, Wealthy, Sexy, and Wise, till 101 and beyond. How many of you would like to live till 101 healthy? Wow, this is not the audience, obviously. Okay, 2 people. Okay, good. Okay, today I'm going to talk about the biomat. It's going to be a very interactive presentation. I need your interactions. And if you do interact with me and answer some questions, I'll give you a reward. How's that sound? Is that good? How many of you had your coffee today? Did you change the decaf or something? Or did you? It's not working. Okay. So, how many of you heard of the biomat? Only one, because I talked to you yesterday. Yeah, it's not very common in Canada and the US. I'm actually from Toronto, Canada. How many of you heard of Toronto? Only 2 people heard of Toronto. This is 2.5 million people. It's the largest city in Canada. Toronto. We did not wake up yet. Okay, so basically, I want to talk to you about the biomat. There are 3 sizes. It's not one size fits all. 3 sizes. The small one called the BioBelt. You can put it in the belly here. And this is called the mini mat. And the big one that you lie down on is called the full professional biomat. Okay, what does it do? Let's first talk about what it's made up from. So basically, it's made from an amethyst. How many of you heard of an amethyst precious stone? Okay, excellent. Which produce far infrared and negative ion, correct? And that tends to help to reduce pain. Okay, whether it's chronic pain or whether it's acute pain. Dr. Arun yesterday mentioned about multimodal usage for managing pain. So I'm not going to talk about medications right now, although I taught in the faculty of pharmacy for 25 years. I know quite of the allopathic medicine approach and the intervention approach. But clients come to us with lots of medications and they need to manage their pain. So we use something like this and some natural stuff to help them to recover from their pain, either motor vehicle accidents or pain from injuries, autoimmune disease like fibromyalgia, lupus, MS, Lyme disease, any kind of pain that you have. Neck pain, back pain, elbow pain, spouse pain. We deal with all kind of pains that we have in our clinic. Okay? You did not get this joke, right? Okay. So we're going to give you some brochures at the end. And if you participate and you wake up, I'll give you one of those books, which is worth $20. Okay? $20. I'll give it. Oh, see, he participated. Thank you. Here you go. I need some people to talk to. I need to talk to live people. Okay. So I'm going to actually ask for somebody to sit here for 5 minutes and give me their opinion, how they felt in 5 minutes. You don't have to have pain, okay? Can I get some volunteers? Oh, we have some volunteers walking in. Come on in. Come on in. So have a seat. Actually, I've seen Needy yesterday, and she sat on it for about 10 minutes. I scanned her body before and after, like I did with my study here that was published. And I asked her how she felt after that. And then she will tell you while she's sitting here relaxing how she felt after the 10 minutes of lying down on the biomat.
Yeah, actually, I was just feeling the pain here and here, and it's just like a really a miracle. I don't know, this is just at some points, and after that, I just sit onto the warming bath, and yeah, I was feeling sleepy. I was feeling like totally relaxed, and it was beautiful. It's just a kind of miracle for
Did
me.
you say you felt sleepy?
Yeah.
I'm not going to put any one of you here because you're already sleeping. There's no need for me to put you here because, okay, sorry, carry on. Carry on. Sorry, cut you off.
So it's like, and he scanned my full body. He just check out my blood sugar and my physical activity, like how I'm doing. And he just gave me the therapy for the 15 minutes. And what I realized, there was the 5% change in my mental power after getting this therapy. So of course, it's good. After that, I just spoke to even Jay also. You must try this. You'll get relaxed.
Thank
At
you.
least you have to be try it once. It's really good.
Thank you so much. Yeah, let's give her a hand. Good. Okay, you wake him up. I could not do it. You've done it. Do you know how many speeches I've done in my life? Do you know how many? I taught for 35 years. And I spoke to over 1,000 companies all over the world. I haven't never ever had a quiet audience like this audience here, right here. This is amazing. You must be hypnotized somehow. I don't know. Thank you so much. Let's give her a hand again. Come on. Thank you so much, Needy. Thank you. All right, can I get Joyce to come here, please? And just give me a short story and how did you get into this and how did you get to work with me?
Massage therapist for 30 years,
Sit down.
chronic pain,
Mhm.
tendonitis, and carpal tunnel, and I was having to retire. And 1 half-hour session on that mat, my pain completely went away. So I said, I gotta have this. And my husband said no. My husband said no, and but then 3 days later, my pain started coming back. So it did not heal me, but it alleviated the symptoms. And after the 3rd day, I bought it. And now I'm retiring from massage because I am sharing this product all over the world because it is covered by Flexible Medical Health Savings. It's a FDA cleared medical device. I had Cigna Healthcare cover a man who was on a morphine drip, and they took him off morphine because of this mat. So it's amazing.
Thank you, Joyce. Let's give her a hand. Thank you. Wonderful. Okay, Helen, you want to come and sit, sir? Come on in. Yeah, please. Come on in. Come in, Doc. Our doctor from Brazil here want to sit on it and try it.
No, from Nigeria.
Oh, Nigeria. It's close enough. Sit down.
Well,
Yes.
thanks for the privilege and the honor. I had an opportunity to have a taste
Okay.
yesterday evening. I was coming from Africa. I had a 13-hour trip to Atlanta, 2-hour trip to Maryland, and another 2-hour trip to Chicago.
Wow.
So you can imagine how tired I was. So they gave me the privilege to just lie down and experience what it was about. It was a different level of relaxation. I was just imagining. I've heard about massage, hypnotism, and all those stuff. What is this one doing to me? As a medical doctor, I started asking questions. But the lessons learned was that when I got back to my room, I did some reading, gave me a book.
Yes.
I was able to actually comprehend what it was all about, and I was so much relaxed. I slept like a baby. I was just, for somebody who expected to have a jet lag, I was very much relaxed, and I did my work, and I was.
That's wonderful, Doc.
But I was just wondering, say, look, but this is unaffordable from where I come from. But it's
wonderful.
something that will suit people's nerves. improve their emotion, and give them agility to be able to do.
And you invite me to come to Nigeria to present this to all of your clients. And you have the first. Okay, so now I'm not going to talk about, because that would be a very expensive bill here. Only me and this doctor. I love this doctor here. This doctor here is just amazing. So me and him, okay, and then we'll go to Nigeria and we'll do this at your place. You'll be the first clinic in the whole country of Nigeria to talk about the biomat, and our friend doctor from Brazil here also invite us to do that. Okay? Excellent. Well, let's give him a hand. Thank you so much. Thank you. Let's give him a hand. Good. Okay, Helen, come on in, please. Helen and Joyce traveled with me all over the world. We went to Barbados. We went to exotic places like St. Lucia, Toronto, Colorado. Anybody know where Colorado is in the U.S.? Okay, only one person. Okay, sit down. Only one person. Helen.
Okay, I'm the type of person who actually sometimes sets out to prove things wrong that seem ridiculous or unbelievable. So I'm a hairdresser and a massage therapist. I'd been in a car accident treatment with every kind of back and pain specialist imaginable for 2 years, unable to make any progress. And I tried a biomat just out of sheer desperation. Borrowed one, brought it home, called 20 people I knew who had anything from psoriasis to sleep apnea to arthritis to any kind of pain, and said, I want you all to come every day, 1 hour, give me 1 hour, because in 14 days I'm going to want to tell somebody why this didn't do what they said it did. And then I couldn't get rid of them. We all had to have one. It's effortless. You sleep on it every night. I'd also broken my hand in the meantime. 4 knuckles, 3 complete breaks, and when they x-rayed, they discovered bone tumor. They wanted to drill that out. I was here at a major hospital in the city at the Northwestern University, Dr. Nagel. I became one of his case studies. He told me it would take 1 to 2 years for my bone to become its own, to be able to have any kind of impact, volleyball, clapping, things like that. And all I did was, post-surgery, fold my hand in this mat twice a day, and within 3 months he called all of his colleagues in the room. I have no scar tissue. He said it looks like we've never been in there. So what they done is they drilled the tumor out of the bone, filled it with a bone powder substance, told me to wait, and 3 months later you couldn't tell it was even there. So going from that to I'm at that age, hormone related as well. I was in menopause, and after several months, no night sweats, no nothing, had all the blood work, and it continues to amaze me. So the negative ions, combating the acid in your blood, the relaxation, the sleep, all of it, pain-free, has just been shocking. So thank you.
Thank you so much. Let's give her a hand. Thank you. All right. So what is this wonderful medical device, as Joyce said, approved by FDA and Health Canada, exactly do? It actually produces negative ions and far infrared that help to penetrate your body and give you this gentle heat. And that's where the word thermotherapy comes from, because when you raise your body temperature by 1 degree, you tend to actually heal lots of cells, lots of tissues, lots of organs in your body. So what happens is when you actually let somebody sit on it or sleep on it, it changes the REM sleep. It reduces inflammation, reduces pain, increase circulation, and actually achieve alkaline pH. So this is the exact summary of this device right here. There's lots of studies done in Asia, particularly in Korea, where this one is manufactured, because people in Asia, they actually far advanced than us. Like none of you heard of the biomat. And some of you heard of integrative medicine, of course, besides Dr. Hal here, who is very well known. I actually heard from him the first time I've seen him. I have not even introduced myself to him as yet. Dr. Hal, could you come over for a second? Because I heard a lot about you, and I heard a lot of good things about things that you do in Cincinnati, Ohio. By the way, in this country, in the US, there's lots of pioneers like Dr. Hal. Oh, bring your coffee with you. Yeah, you can bring it with you. Because you're going to sit here for 5 minutes. I don't want the coffee to get cold. I want to experience that. Okay, so okay. I paid him a lot to actually, this is the first time I met him. Okay, here's my card. And this is for you, sir. Thank you. You're very welcome. So when people sit on it, you feel like somebody hugging you. So when I sleep on it at night, I feel like somebody hugging me. So if my wife is not there, This is my second wife. Don't tell her I said that, okay?
My girlfriend's a Matt.
By the way, guys, laughter is the best medicine. If you really want to live to age 101, you have to learn how to laugh, all right? If you don't know how to laugh, just take your clothes off and look in the mirror, and then you have the best joke in front of your eyes. Anyway, let's get serious here for a second. This biomat, I studied for 12 subjects, and I measured in Colorado the difference in a young girl. Her name is Connie. And the results, I used a biofeedback called ICAP from MIT. How many of you heard of MIT? Okay, that's okay, excellent. That's actually what I did, and I measured their brain scan, their heart scan, Nerve Express, and ICAP, and there's a difference in the 20 minutes that she was sitting on, was shown here with this kind of biofeedback device. And we did the study on using not just a biofeedback, we actually did the study also using CBC blood test, 12 hours fasting, and we have seen difference, even LDL cholesterol gets lower, the HDL gets higher. We're not competing with statin. I'm not here to take business out of Zocor, Lipitor, Provocol. No. All I'm telling you is that this is what we found in our test. HSCRP. How many of you, all of you are pain specialists, you better put your hands up for this one. How many of you heard of HSCRP? Don't tell me. Really? CRP, HSCRP. Only one doctor? Okay. Yeah, exactly. Oh, yeah, absolutely. You guys never heard of HSCRP? What's going on here? High sensitivity C-reactive protein. I'm sure you heard that. Yes. Okay, so this is actually a measure of inflammation in the body. Yes, Dr. Ziad? You heard about it. Why didn't you put your hands up? You guys have to respond to me. Come on. When I ask you questions, answers, I can give you a book. So the doctor left, okay. Yeah, left at my jokes. Okay, good. Excellent. So this is phenomenal. When you have a device like this, Dr. Hal is very well known in the US about integrative medicine. How many of you heard of integrative medicine? Okay, excellent. This young lady gets a book. At least she knows where Colorado is. Oh, you're very welcome. Integrative medicine, functional medicine, if you haven't heard about it, in 5 years it's going to be a common household word. Yes? How many of you heard of Dr. Andrew Weil, Cleveland Clinic? Okay. They're all studying functional medicine. They're all studying integrative medicine, and that's the medicine of the future. And you better, if you only study allopathic medicine, like I did, taught in the Faculty of Pharmacy for 25 years, you have to widen your scope a little bit, especially if you work in this field right here, the multimodal system, where you manage pain not just with one drug or multiple drugs, or surgery with other method as well. All right. So this is all I wanted to tell you. Now, Dr. Hal, how long have you been sitting here now? 5 minutes or less?
Maybe 10.
Okay. So tell me, honestly, your experience, how does it feel?
It's warm.
Okay. Beside the thermotherapy,
Cozy.
beside the warmth, is there any changes?
Changes.
Like you find anything happening? Any subtle changes? Like more calm, like more relaxed? Sense of equanimity, sense of peace?
It's hard not to be more relaxed when there's something warming your butt up.
Absolutely. Especially if it's in Toronto minus 10 below zero, like 10 degrees below zero. Or I lived in Saskatchewan, it was 40 below zero. How many of you heard of Saskatchewan? Yes. When it's 40 below, when you have this mat, I'll tell you, you feel like more than somebody hugging you when you have this kind of feeling. Okay, what else? Like, would this something that you'd like to know more about, would like to read more about it? By the way, this book that I just gave you, it has hundreds of references in Asia. Read that, like our good doctor from Nigeria here read yesterday, and he's very kind of wanted to know more about it. So this is the stuff that is not yet, but now we're just bringing it to your attention as another, one of the modality that you can use in your clinic and your practice. Okay? Any other comments you want to offer us? No. Let's give Dr. Halla a very big hand. Thank you so much. Thank you.
Thank you.
Thank you so much. Anybody else want to try this?
Dr. Rank, can I mention just a couple things?
Of course you can. This is open discussion.
I could probably talk loud enough.
Sure.
Something I've
Okay.
noticed with my clients, again, because I deal with a lot of people who have chronic pain problems, who have tried quite a bit of things, who are just managing pain. What they have said they liked about it that is burning your skin, never getting to, the core, which is like a micro massage. I think that's
Mhm.
why a lot of people feel very relaxed and comforted. It changes their breathing. You're already yelling at me about not fully breathing.
That's
One of
right.
the things you notice first is
Mhm.
when you lay down, and that's, I call it effortless. All
Mhm.
these people, they're just sleeping. They're just laying down, and they're learning to breathe again, the deep breathe, the belly breathe. They're completely getting a micro massage, a very relaxing. They're sleeping the way they never slept, and they're able to can't even be manipulated by hands are being reached by this micro massage.
Thank you very much, Helen, for mentioning this, because most of my clients, I have 7,000 all over the world. I travel twice a month. They breathe from here, shallow breathing, from the chest. They do not know how to do diaphragm breathing. And as soon as you teach them how to diaphragm breathing and sit on the biomat, their pain reduced by 10%. I've done this, I'm telling you, 7,000 clients all over the world. If you can teach your clients, let's assume, what if now? What if you used medications? What if you used all of the, narcotics? What if you used all of the nerve blocks? What if you use something like this and it works? Just another, things in your toolbox that you can use as a doctor. And that's what I want to share this with you, because if you increase oxygenation, in fact, and you increase alkaline pH, you'll be in excellent health. Is there anybody who have neck pain or back pain? And I just want to see you for 5 minutes. Yes, you do? Come over here. What's your name? Michelle. Okay, Michelle, come over here. So what I'm going to do for Michelle, I'm going to actually test her range of motion first before we do anything. Let her sit here for 5 minutes. I do not do chiropractic. I do not do any cracking. Okay? I'll just test her range of motion. So Michelle, you've been traveling from where? Where's your home?
Washington, D.C.
Oh, that's not too far. I drove from Toronto. Can you imagine to here? Okay, so move your neck this way all the way. Okay, this is supposed to be here. She's off by this much. You see that? And here, this side, she's off by this much. So she has neck pain right now. Not severe. I have some clients who have fibromyalgia. You know what they do? I say, move your neck. I'm moving it. There's no range of motion. Do you understand? Now, you put them on amitriptyline, you put them on FXO, you put them on any drug in the world, it's not going to matter. Seriously. They have autoimmune disease. So medication will not work for them. Okay? So Michelle is sitting here, and all we have to do to find out where is the area. I'm sure you know all of the anatomy about the 7 cervicals. Just a tiny bit here. Tiny bit tension here. You can sense that. All I'm going to do now is just basically stretch. That's it, stretch. In fact, before I do anything, we do kinesiology just to test her strength before I do anything. So try to resist, Michelle, please. Okay, so she has hard time actually to resist. Yeah, very difficult her to even one finger, she's unable to resist. Now, if we can actually change this in 1 minute without doing any invasive stuff, sitting on a biomat for 2 minutes and just doing stretching, and just all you have to do, take a deep breath. Excellent. 1 deep breath here. Excellent. And 1 deep breath here. Excellent. Oh boy. You see how tense you are here? Okay, go like this. I don't do massages, sorry. Okay, 5 times. Go 1, 2, 3. A little bit stronger, Michelle. Yeah, 1. Go down. 2, 3, 4, 5. And then just backward a couple times. Good. And then forward a couple times. Like roll it, like rowing a boat. Yeah, like this. And then stretch here. One stretch. 1, 2, 3, 4, 5. 1, 2. Very gentle stretch. 3, 4, 5. How long sat on mat? Less than 2 minutes. Yes? How long I did this? Less than 2 minutes. That's the answer, right? Watch this now. Strong now, Michelle? No, don't do this to me, please.
Sorry.
Okay, strong. Good. Strong. Is she stronger? Yeah. Is she stronger? Yes, thank you. Move your neck this way, Michelle. Is she moving further?
Yes.
Thank you, Doc. Move the other side. Now, how is your neck feeling?
It still hurts on the left, but not as bad.
On this side here?
Yeah.
Okay, so all I do now is just ask her to breathe. Just belly breathe. I only have 2 minutes sign here. I'll finish in 2 minutes, I promise you. Just breathe. 1, 2, 3. Now, which one is better, to do this or to give her morphine or codeine? you know, it's a choice, obviously. I mean, you're the doctor. You decide which one to use. But if you use all of these methods and nothing works, by the way, how are you feeling about the biomat? Okay, let's not say anymore. and how's the pain here? Okay, since I only have 1 minute left, we got the biomat outside. You can come talk to me. I'm not going to scream at you. I'm very gentle. Okay? And then ask any questions, because my time is expired, and our good doctor is going to be speaking after me. So with that, let's give a hand to Michelle. Thank you so much. Thank you. Thank you. And hands to you, because you listened to me for the whole 20 minutes and for your participation as well. Now give this hand to you, not to me. Thank you, to you. Thank you so much.
For clinical management by factors. There is a great variability in medical practice, even within developed countries, which can worsen the outcome of the treatment and justifiably increase the risk of iatrogenic and health care costs. It is a leading health problem across industrialized nations. Also, the trend of rising of chronic low back pain is associated with high rates of disability. Neurostimulation, introduced by Shelley in the 60s past century, is primarily implanted in the United States for Feilerback syndrome and complex regional pain syndromes. Neuromodulation might be a reasonable, effective therapy for patients suffering from back or neuropathic pain, including Feilerback surgery, where there is no other alternative therapy. It has several advantages compared with reoperation. The Eurobarometer is a part of European Commission Health and analyzes various aspects of European citizens' health. Musculoskeletal problems affects 22% populations. A third of respondents had experience of pain prior to the survey. pain most common type was low back, affects 67 million of European people. The 55 age group is the most likely to have restrictive pain. Each year, 1 in 5 adults in Europe has low back pain. It is the second location more frequent of pain. Only 10% of acute cases, etiology, shall be identified. Chronic pain lasts more than 3 months and affects 10% of cases. Low back pain is the most common cause and orthopedic industrial face disability of workers under 45. Those who have medical care, 30% have radiated pain, and only 2% have strong findings of a goal of good surgical results for nerve root decompression. Those with signs of this herniation, 1 in half will recover suitable tolerance of daily activities. Low back pain affects more frequently to the agriculture, fisheries, and construction people. There are very high costs. Around 5% of population with disability generates 75% of health care costs. There are significant geographical variations. 90% of attacks are resolved in 6 weeks. 10% develop persistent pain and frequent relapses. On the other hand, there are many options for evaluation and treatment, but little consensus regarding to the appropriate use on diagnostics and treatment. There is an excessive variation for indication of surgery, and United States is 5 times higher than Europe. Finally, few technologies have often proven or be effective, and even the imaging some based on studies with few benefits. However, those who attend care doctor achieve rapid intensity improvements of pain, disability, and is returning to work. But relapses are very frequent. 7% of patients might present at least 1 year. Diggio and collaborators published one interesting research which examines all aspects related to low back pain and its impact in labor, health, economic, and social system that nowadays is entering in crisis. Medicare spending for inpatient back surgery more than double over the decade, with an increase of lumbar fusion representing 47% of total spending. Similarly, increases in spinal cord implants over a 10-year period have been reported in Medicare population. Management of post-lumbar surgery syndrome with numerous modalities of treatments, including interventional techniques, results in moderate improvement, yet leaves a proportion of patients in intractable pain. From 1990 today, cost has been increasing, and medical treatment is estimated between $9,000 to $19,000 per patient per year, and interventions around $19,000 to $35,000. Developed countries have an increase in interventionist techniques 235% parallel to a rise of prevalence of pain related to an improvement of diagnostics means, and progress new surgery and injection techniques guided by fluoroscopy, echography, or magnetic resonance, including neuronavigation. There are many options for evaluation of treatment of back pain, but little consensus regarding to the appropriate use of diagnostic and treatment media. Excessive indication of surgery in United States is 5 times higher than Europe. Few technologies have often proved or ineffective and even damaging, some based on studies with few results. The European multinational COST B13 program was developed by the European Commission Directorate on General Research Political Coordination and Strategy branch under the title Low Back Pain Guidelines for its Management. Since 1999 to 2005 were reviewed clinical practice guidelines and 871 systematic reviews, randomized controlled trials, and prevention studies involving a total of 49 experts around Europe. For the main difference with previous guides is that includes recommendation for management, acute, chronic, and prevention of low back pain. Interventional techniques of American Pain Society published one guide that recommend limiting the use of these interventional techniques because reaffirms our previous recommendations avoiding intensive invasive therapies and showing benefits of non-invasive. Example, stay active, intensive rehabilitation, and cognitive behavioral emphasis. However, controversy is served because, in contrast, the American Society of Interventional Pain Physicians published a critical review of interventional techniques for chronic pain, acute low back pain that differs from guidelines including caudal epidural injections, lumbar facet joint nerve blocks, radiofrequency neurotomy, and percutaneous adhesiolysis as appropriate methodology. Probably better designed studies obtain a balance between non-invasive and interventional therapies. The COST B13 guide is a pan-European multidisciplinary on scientific evidence funded without participation of the industry and profit institutions. It provides comprehensive management of acute, chronic low back pain and its prevention. In the Spanish adaptation, recommendations related to acute and chronic low back pain were merged into a single temporal sequence in order to improve clinical practice application or in implementation of technologies recommended depending on type of patents and scientific evidence, effectiveness, and safety. Also, we added a conflict of interest declaration by its members and applying agreed criteria to improve quality. It's included in the national health systems of European Community for primary to hospital care. The systematic reviews were identified using the validated share strategies in the Cochrane library. Medline and Bayes, if relevant, other electronic databases performed for clinical evidence. A three-stage development process was undertaken. First, recommendations were derived for systematic reviews. Second, existing national guidelines were compared and recommendations from these guidelines summarized. And third, the recommendation from the systematic Cochrane reviews and guidelines were discussed by the group. A section was added to the guidelines in which the main points of debate are described. The recommendations are set in a clinical relevant order. A grading system was used for the strength of evidence and level of evidence recommended in the method guidelines of the Cochrane Back Review Group. Several systematic reviews have included non-English language literature, usually publications in German, Danish, Spanish, and sometimes Norwegian, Finnish, and Swedish. The working group aimed to identify gaps in the literature and included recommendations for future researches. The distribution of the cause of low back pain are by frequency: common low back pain, 90%, symptomatic herniated disc, 4%, ankylosis, 0.3%, and compression fractures, 4%, spinal malignancy, 0.7%, Van Tolder study. Pain can occur in different ways. Episodes acute last less than 3 months in more than 90% of cases, which are usually benign, and they can be treated with simple steps. Usually this corresponds to the type non-specific, but others may be due to other causes and therefore must evaluate and treat specifically and quickly. Chronic pain lasts more than 3 months and constitutes about 10% of cases, but generates high costs. The key to preventing the acute pain onset and chronicity is implementation of preventive measures. Can be integrated into low back pain clinical course, diagnostic, therapeutic, preventive actions to optimize long-term results. This classification may seem simplistic, since in many cases the pain yields around 6 weeks. For this reason, it has introduced the term subacute to see episodes that reach between 6 and 12 weeks and are warning signs called yellow flags, need new evaluations and treatments. In absence of serious spinal pathology, specific non-spinal etiology, or progressive neurologic deficit, management should focus on patient education, self-care, analgesics, and exercise. Short-term relief in radiating pain may be obtained with epidural blockade with local anesthetics and perhaps is discussed nowadays, steroids or father blocks in selected cases. According to scientific evidence, neuromodulation techniques, including peripheral neuromodulation and neurotherapy, can offer good results in low back pain, avoiding surgery and providing functional recovery. What are we doing about it from EASP? The purpose and mission of the group of neuromodulation is to promote interdisciplinary collaboration among scientists, clinicians, and other professionals within the healthcare networks, worldwide in research and clinical application of neuromodulatory treatment strategies, facilitate interprofessional education and training in the field of neuromodulation, with particular attention to the clinical application of emergent neuromodulatory techniques for pain and symptom management, and establish a platform and forum for ongoing professional discourse in order to address emerging and navigate the development of evidence-based practices and policies. In this way, our group has been promoting cost-effectiveness research and clinical application of neuromodulatory treatment strategies. Cost effectiveness was evaluated in 2 systematic reviews and 3 studies with positive results. Really, the addition of neurostimulation in patients with neuropathic leg and back pain results in higher cost to the health system, but also generates important improvements in patients' functional and health status over the same period. During the first 2 years, during the first 2 years, the cost was higher than conventional pain therapy, owing to the initial high cost of implantable devices. After this period, however, the cost for remained significantly lower than that for conventional pain therapy, whereas quality of life results showed a 27% of improvement compared with conventional pain therapy in terms of patient satisfaction and return to work. If a societal perspective were considered, neurostimulation will be more cost-effective as more people return to work compared with those treated with conventional pain therapy. Particularly, our group make attention to the clinical application of emergent neuromodulatory techniques for pain and symptom management. PANs should not be confused with transcutaneous nerve stimulation, TENS, in that the effects do not correlate with TENS apply externally over the same area. Although neurostimulation creates a local electrical field, at thus TENS the field is narrower and produces higher current density. Effective stimulation to pain of no hematomal distribution proved to be equally successful for achieving pain control to the stimulation provide to definitive neural structures such as nerves or plexuses. Overall levels of pain relief were reported to be 80% of all cases, with varying durations of relief from several hours to up to 3 months. The out of favor older radiofrequency systems are likely to return to favor for pins as they do offer an attractive, relatively inexpensive solution to spiraling costs of healthcare for pain syndromes, especially when neuromodulation devices are used. Pain in certain syndromes, complex regional pain syndrome, phantom limb pain, is associated with a functional reorganization and hyperexcitability of the somatosensory and motor cortex. Studies showing that the reversal of cortical reorganization in patients with spontaneous or provoked pain is accompanied by pain relief stimulated the search for novel alternative how to modulate the cortical stability as a strategy to relieve pain. Recently, non-invasive brain stimulation techniques such as transcranial magnetic stimulation and transcranial direct current stimulation were proposed as salutable methods for modulation of cortical excitability and analgesic effects induced by TDCS outlast the period of stimulation and are cumulative, transient, and site-specific. Axial back pain demonstrates a statistically significant reduction with peripheral neurostimulation in a pan-European study and registry of efficacy. This was used as supporting evidence in the successful application for approval of PNFS in the European Union. Courtney and colleagues recently represented data describing superior and middle cranial nerve stimulation with or without spinal cord stimulation in the treatment of axial pain in patients with failed back surgery syndrome. As reported, the patients continued to have dramatic reduction in pain scores and significantly improved OS3 disability scores. Recent reports have appeared using epidural stimulation in combination with PNFS, termed triangulation by our colleague Elliot Krames. This method can be more efficacious than either techniques used alone. The EASP announced this year as Global Year of Neuropathic Pain. Which consequences of these announcements are implicated by our group? Neuropathic pain is defined as a pain that arises as direct consequence of a lesion of diseases affected to the somatosensory system, including lumbar or cervical radiculopathy, chronic post-surgical pain. Recent guidelines were published according for the grading of recommendations assessment development of evaluation system. Nevertheless, these recommendations, it is well known that still many patients with neuropathic pain are not adequately treated. Neuromodulation techniques can be very helpful, especially in neuropathic pain syndromes. In summary, it's essential to investigate further for underlying structural etiology and assess whether the spineful symptoms indicate a systemic process. An emerging evidence base suggests that chronic low back pain may originate in dysfunctional nociceptive processing within the central nervous system. Misattribution of pain to direct peripheral nerve injury might lead to poor clinical outcome. For this reason, it seems neuromodulations offer emerging possibilities related to these findings. In the future, neuromodulation will be an important role in management of disease. New efforts are made by the International Association for the Study of Pain, International Neuromodulatory Society, and the European Academy of Neurology for published new recommendations with regard to neuromodulation techniques. In order to get access with neuromodulation techniques into therapeutic algorithms for neuropathic pain, members of our group are called upon to start well-designed studies for invasive and non-invasive stimulation techniques can serve as new work for all of us to create and perform such studies. Many thanks.
Hold on. Okay. There we go. Can you guys hear me okay? Thank you for having me. My name is Michelle Layton. I am a physical therapist. I work full-time at Bethesda PhysioCare, and I am also a senior instructor for MyoPain seminars teaching the dry needling courses. And I want to talk to you a little bit about how dry needling can be a useful treatment option for patients who have chronic pain of various reasons. So basically, what is dry needling? Dry needling is basically, it's a skill that can be used by many different professions, including physical therapists, depending on the state of rulings. But basically, you're using a solid filament needle to insert into the tissue to treat not only the muscular trigger points, but also the perineural tissue, scar tissue, etc., in order to help improve the musculoskeletal impairments that patients typically come in for. So basically, it is used most commonly for myofascial trigger points, and this is where most of the research has been done. A trigger point is considered to be a hyper-irritable nodule within a top band of skeletal muscle, and with that, it can cause various impairments within the musculoskeletal system. Oftentimes, people are not recognizing muscle as a source of pain, and because of that, a lot of patients with myofascial pain do not get diagnosed quickly. One of the issues with the muscle pain is that it can present almost like it's a joint problem. It feels like your bones can hurt because it can refer to those deep somatic tissues. With that, it can not only refer just pain, but it can also refer numbness and tingling and other sensations, even hot and cold. So the perception of where the problem is, according to the provider, can be very confusing, because it's what the patient's experiencing, and it doesn't necessarily indicate that a problem or a nerve problem, a muscle or a joint. So being able to recognize muscle as one of the potential contributing factors is important in the management of patients with chronic pain. We do know that myofascial trigger points are a source of peripheral nociceptive input. There's been lots of research looking at the chemical makeup of these tissues and what they contribute to, and that they can also contribute to not only peripheral sensitization, but also central sensitization. So because they are a source of peripheral nociceptive input, they can continue to bombard the nervous system and lead to wind-up. And therefore, treating them can help to downregulate the system in conjunction with other therapies as well. So to look at the chemical makeup tissue, research has been Shah over at NIH, and this is the system that they basically used with the microdialysis pump with a special solid filament needle with 2 tubes inserted into it, and then another plate in order to measure the chemicals that were pulled out of the tissue. So this is what the needle looked like. This is a standard needle that they used, that I actually used for treatment. It's 0.3 millimeters wide, just to give you an idea of the thickness of the needle. Very, very thin. And then what they managed to do was put these 2 tubes, oh, it's not working, there we go, put these 2 tubes into that needle, make a membrane, and then they were able to measure the substances within the muscle. So as you can see here, once the needle was inserted into the trigger point, and then fluid was pushed through the one tube and was pulled out the other, and with that pulled the chemicals that were in that immediate area of the trigger point. And then with that other plate, they were able to measure what was actually in the trigger point. So what they found was that there are differences between active and latent trigger points. Active trigger points are the trigger points that typically refer the patient's familiar pain, and they found that there is a significantly lower pH in these trigger points compared to latent and then compared to normal muscle. So if you look, this blue here is the active trigger point, this green is the latent, and that red is the normal muscle. They also found that the pro-inflammatory substances such as substance P were significantly elevated at the trigger point compared to the green, which is the latent, and the red, which is the normal. Other pro-inflammatory substances that they also found elevated included your calcitonin gene-related peptide, your interleukins, your tumor necrosing factor, serotonin, etc. So all of these chemicals are basically within that tissue perpetuating a problem in the periphery that can, again, continue to bombard the nervous system and lead to wind up within the nervous system. We also know through visualization of trigger points using vibration ultrasonography, and the trigger points look like this hypoechoic point here, that they can contribute to a lack of blood flow through that immediate area. As you can see down in through here, that blood flow does not look as nice and pretty when there's a trigger point as there is a normal muscle here. And this was taken at a trigger point within the upper trapezius, looking at this ascending branch of the transverse cervical artery. So if you can envision that in addition to these pro-inflammatory substances and also not having good blood flow through the area, it's going to be very hard for the tissues to be able to heal. And with the lower blood flow to this area, it's going to cause a lower oxygen level, which will also, in addition, contribute to a lower pH within the tissue. With that, we know that a low pH by itself can not only initiate but maintain muscle pain and activate those acid-sensing ion channels, in addition to all of these other pro-inflammatory substances. So with that, we know that the muscle nociceptor can become sensitized. With that, it will then send information through the dorsal root ganglion into the dorsal horn, and then with the constant bombardment of those nociceptive inputs, as you can see, it's going to release those chemicals, the bradykinin, the substance P, the CGRP, in the dorsal horn. They will then bind to their respective receptors. You'll get an excess release of calcium, which then actually facilitates the release of more calcium. And as you can see here, the slide gets very busy of lots of things going on. That extra release of calcium is also going to activate secondary messenger pathways. So it's no wonder that patients with chronic pain are really challenging to manage just from a neurophysiological perspective, because one little process can facilitate so many different things, and this is just in the dorsal horn, that can then feed up with enough frequency, intensity, and duration from the dorsal horn up into the cortex of the brain. And then this is where we start to perceive that nociceptive input as pain. And depending on which part of the dorsal horn the input is coming into, it will then travel up its respective to the different parts of the brain. That way we not only perceive the pain, but there can be an emotional component with it as well. So that's why we can remember what happened when we broke our leg in that car accident, and maybe what music was playing and how we felt, etc. It's because we get that emotional relationship because of the parts of the brain that give us that. And we know that with functional MRI imaging, muscular tissue can also light up these areas of the brain, as you can see with the rostroventral medulla and the periaqueductal gray area. So in addition to these trigger points causing pain, there are many other effects it can have on the neuromuscular system, and this is why it's important for physical therapists to be able to recognize and treat this problem. So in addition to pain, we know that they can cause local tenderness. So when you do use a pressure algometer to measure the pressure pain threshold, you can see here that in those with shoulder pain and active trigger points, that pressure pain threshold is going to be significantly lower than those who do not have pain. So basically, you can barely touch the patient and they're going to report pain. This is not necessarily that they're crazy or that they're exaggerating or anything along those lines. This is how their body is perceiving it. Their threshold for input is significantly lower. The trigger points can also contribute to disturbed motor function, and this is a lot of what we do as physical therapists. We look at how muscles perform and how patients move overall. Latent trigger points, so these don't even necessarily need to be in patients who hurt. These are patients who come in, they don't hurt, but maybe you assess the tissue and you find some trigger points within the top bands. Those trigger points can alter the muscle's ability to fire properly. So imagine someone who does a lot of overhead activity and they have trigger points in their scapular muscles. Over time, they can contribute other problems and potentially develop pain down the road. Trigger points can also affect the muscle's ability to reciprocally inhibit. So if you consider performing shoulder flexion, and if you have a trigger point in your posterior deltoid, that posterior deltoid is not going to be able to properly relax for your shoulder flexors to be able to do their job, okay? Which means those shoulder flexors are going to have to work harder in order to be able to do their job. And that's another mechanism that can contribute to the development of trigger points in those shoulder flexors. What's interesting is that even trigger points in the cervical spine region for those who have myofascial pain, it can affect their postural control and balance. Work on all your vestibular rehab and lower quarter balance training, and if you're not recognizing that potentially myofascial trigger points in the upper quarter region can contribute to this problem, you're still going to continue to have problems. Trigger points can also contribute to decreased range of motion. And if you look at this study here, there was no actual control group, but just clinically, these patients, there was a significant improvement in not only their pain, but also their range of motion of opening, lateral deviation to each side, and protrusion. This is the difference of someone being able to eat a sandwich like a normal person versus being able to cut it up into pieces because they can't open fully. If you look in the gastroc and soleus, trigger points there can affect ankle dorsiflexion. And for someone potentially who is elderly, who has difficulty clearing doorways and low piling carpet, this can be very important, and you can mobilize the ankle and strengthen all you want, but until you address this underlying component, they can still have problems with their mobility and be at risk for falling and then hurting themselves. Trigger points can also contribute to muscle weakness and inhibition. So again, looking at latent trigger points compared to patients who don't have trigger points, strength is significantly less. Trigger points can also affect the fatigability of muscles. So if you envision that the muscles constantly firing at some low level capacity, it's no wonder that patients will fatigue more easily or have difficulty with exercise. In addition, trigger points can also cause stiffness. So if you look at the tissue here, the one on the left is normal muscle, the one on the right is where a trigger point is, and the tissue quality is very different when looking at it through magnetic resonance elastography. So now that we know that trigger points can affect the neuromuscular system, is the treatment of them with dry needling effective? And this is where it certainly does depend on the patient population, and you have to do other treatments as well. But when you look at this patient here, this was dry needling done before and after. Here it is in the standing position before dry needling, here's in the prone position, and then here's after. So you can see that, number one, positions do make a difference. And if you imagine palpating the upper trap and sitting versus prone, there's a definite quality change. Even with that, after you treat the trigger points, the tissue quality is much better and the stiffness is significantly reduced. And this is something that can be palpable as well with your patients. Going back to that person who had altered muscle firing patterns, okay, treatment of those trigger points can start to normalize those muscles, so the muscles that are supposed to fire first actually do. When you look at comparing dry needling to lidocaine injections, systematic review, only 5 studies made the criteria. They found that both were effective. So from a physician perspective, they're most likely going to do trigger point injections, but maybe patients can't get to the physician as often, maybe physical therapy is a more viable option, reimbursement, etc. So basically, if dry needling is as effective as using lidocaine injections for trigger points, then this is a very good option for patients to continue to have access to the treatment that they need. This was one of the first studies published in our more common physical therapy journals, which is good because as a resource for us, a lot of the other articles published are in journals we just don't have easy access to. And basically, compared to placebo or sham, we know that dry needling is effective. And we know it's at least effective in the immediate, in the short term. So do longer studies need to be done? Absolutely. But maybe this is the difference so someone can go home and do their home program more effectively and be more compliant. Maybe they can go take care of their kids or cook that meal that they struggled with before. Looking at dry needling in those who need a total knee replacement. I think this topic had come up briefly yesterday. So what they did in this study here is they took 40 subjects, they evaluated them for trigger points in muscles related to the knee prior to having the surgery. Then the patients were, they received a spinal block, so they couldn't feel anything from the waist down, and they also had a visual block, so they couldn't see anything from the waist down. They were randomized into one of 3 groups, so either the true dry needling group, the sham dry needling group, or the control group. And if you look at this, and these patients were needled right before the surgery, those who had the actual dry needling, their pain was down in 1 month compared to those who 6 months out finally got to that same pain level. So now, looking at that, this again is important because this is the difference of someone being able to get back to work more quickly. This is the difference of someone not taking the pain medication that may not help them, that may give them other secondary effects as far as GI issues, constipation, nausea, vomiting, poor tolerance to eating. So if we can help manage their pain and impairments prior to surgery, then they're going to have a much more successful outcome post-surgically. Looking at a Cochrane review, they looked at dry needling for chronic low back pain, and they did find out of the 35 randomized controlled trials that it is effective. However, it's not a standalone treatment. It's useful as an adjunct. So this is done in addition to your other treatment regimes as far as exercise and posture, education, etc. And although this study here is not looking specifically at dry needling, it is using trigger point injections, I thought it was worthwhile to include because patients with fibromyalgia are very difficult to manage. And if you look at this, they did an injection just into the upper trapezius, not in anywhere else within the body, and I believe it was with 1% lidocaine. And it not only reduced their local symptoms, but their widespread symptoms, their spontaneous pain. So where do you currently hurt? All of that reduced, and the tenderness in all of those fibromyalgia points was also significantly reduced from a single injection into the upper trapezius. So if we can help to decrease that peripheral nociceptive input into their system, we can then start to down-regulate everything so they can get back to a more balanced, manageable life. So again, maybe they can tolerate doing their home program. They can tolerate getting into an exercise program at the gym or at the pool so they can start to become more compliant. Because it is very difficult for patients who hurt to understand that pain and injury are not the same thing. So if we can reduce that in some capacity, they will be a lot better. And I already alluded that this is not a standalone treatment, and this is just to kind of piggyback a little bit off of what we had talked about yesterday as far as dietary and eating well. A lot of the patients I see have very poor eating habits. They do eat a lot of processed food. They're gluten intolerant and they don't even realize it. So I strongly advise patients within my clinic to make sure that they are trying to modify some of these things, although now I know that it needs to be longer than just a couple weeks. So thank you, Hal, for that information. But you don't need to be allergic to have a problem. You could be sensitive. So your allergy testing will not pick these problems up. Also ruling out vitamin deficiencies and, more importantly, inefficiencies. So the low level of normal for your vitamin D and your vitamin D may not be sufficient for that patient, and giving them the boost that they need is sometimes helpful to manage their symptoms more effectively. Just to also follow through with sleeping, patients need to have good sleep hygiene. Are they snorers? Are they open mouth breathers? Do they need to get a sleep study to see, do they have multiple arousals at night? Because if they're not getting into good sleep, their body's not going to be able to handle any of the treatments that they get regardless. And then also just a multidisciplinary approach, a psychotherapist, a social worker, psychiatrist, someone to help them manage their coping skills. They may think that they're good at handling their stress, but typically some of their coping strategies may not be the most ideal. So being able to address these factors in addition to all the other physical therapy treatments is important. So I included a couple videos just so you could see here. This is dry needling of the lateral pterygoid. So you have to find the head of the mandible, and I had to protrude for that and go just inferior to the zygomatic process within the mandibular fossa, and then you needle straight into the muscle. So it is fairly deep. Where you will hit, the needle will hit is the back end of the sphenoid bone, so you actually go through the muscle. But I wanted to include this muscle because I thought it would be interesting to see. And again, this is a muscle that can make some pretty drastic improvements with overall jaw function for patients. And this is a muscle that you cannot palpate. Okay, you can go based off of clinical exam and pain, but it is not one that you can access. And the other one I included is also the needling of the infraspinatus. So again, very important to get your landmarks, to know the fiber direction so you can palpate correctly, to find the trigger points, and then inserting the needle right over the trigger point. And then the goal, obviously, with the needling is to not just put the needle in once and remove it, but to try and clear the area of the twitches, which unfortunately the video did not pick up. I was able to see these when we did the video this past weekend, and the patient also reported it. But you can make some very nice changes with these patients by offering this treatment technique. So thank you very much. And if there's any questions, if there's time.
Actually, we are like about a minute over already.
Oh,
Okay, we're out of time. Thank you, ma'am.
Okay, thank you. That's my email if anybody has any questions.
For last 1.5 to 2 years, and this called disc FX, which is basically a radio frequency treatment for intervertebral disc prolapse, and it is also we combined it with a manual removal of the disc material. So basically, what is disc prolapse? We all know that it is disc is annulus fibrosus outside and nucleus pulposus inside, and there whenever there is a crack in the annulus fibrosus, we have a neurovascular bundles growing inside the fissure, which is cracked. So we have a neuropathic pain combined with compression on the nerve. These are the this is the mechanism causing radicular pain, and I'm not going to detail of the pathophysiology of how the disc pain causes radicular pain or back pain. Basically, a technique what we are using and what is the outcome of our patients. So basically, we have normal disc here, and we have annular tear. This is called disc herniation, and we have a disc herniation at various places. We can have a focal herniation in the paramedian or foraminal level. It can be a diffuse broad herniation. It can be a protrusion, which is having a good base, or it can be an extrusion with a small base with a bigger outer nucleus which is coming out. And you can have migration and then sequestration. These are the stages of disc herniation, and depending on this, what we see on MRI, we decide what patient is ready for disc FX treatment or some other treatment. So it's the same thing in a single slide. So basically, what we have to make sure that we have to know the triangular zone, which is a Campbell triangle, which is supposed to be a very safe zone. Normally, when we do the epidural injections, which is transforaminal epidural injections, we go subpedicular, and it is supposed to be a safe triangle there. But in recent studies, they have shown that safe triangle is not so safe, because there may be an artery which is running here, artery, and it can cause injury, and we have seen many in cervical area, many in thoracic area. So many complications have occurred, and a lot of litigations have occurred because of that. So this is the approach to enter the disc, which is a Campbell triangle, which is formed by a root, the posterior margin, the superior part of the vertebral body, and superior articular process behind. I think it's not working. So this is a Campbell triangle, and this is the triangle where we basically go. So to treat the intervertebral disc prolapse, we have various methods. We have mechanical decompression, we have thermal techniques where we use lasers, coagulation, and radio frequency, and we have chemonucleolysis, where we use various chemicals. People have used ozone, they have used methylene blue, they have used a lot of other things, including steroid. So what is disc FX? Disc FX is a eloquence generator, which is a radio frequency generator, and we know that it is a standard practice to use radio frequency techniques within the frequency in the range of 300 to 500 kilohertz. There was a generator which was developed by Eloquence, and it is 1.7 megahertz. It is used for many endoscopic procedures which are used in spinal endoscopic procedures. And a major component of this newly developed intervention is the application of high radio frequency using a steerable probe. If you see a picture, you can see the cannula through which the probe is coming out, and you can steer it in 360 degrees. So you can do ablation in a wider area once your cannula is inside the disc. Now, the safety is very important when you are using anything in the disc, and this technique is very, very safe because you are doing under endoscopic control. You are doing you can put endoscope through this small cannula. There's a small endoscope which is available, and second, the heat which is produced by this is very, very minimal. I'll show the picture. So the reduced heat, thermal convection, and minimal tissue alteration is what is improving the safety of the device. There are two modulation of the during the procedure which we are using. This produces it produces the waveform which is different and having a different tissue effect. If you see there's something called bipolar turbo effect, which causes ablation of the nucleus. So basically, it causes plasma coagulation and evaporation of the nucleus tissue. And second is bipolar hemo, where you apply a radio frequency current over the annulus, and it causes a shrinking effect on the annulus. So it basically burns the nerve which are coming from the annulus, also shrink the annulus. So you try to reduce the size of the disc by shrinking the annulus. So these are the two modes which you use, and you try to reduce the pressure from the exiting nerve. So this is the slide which shows the temperature distribution along the along the steerable radio frequency cannula is very, very minimal. It is not in the destroying zone. It is 21.5 to 32.5. So this is not even beyond 42 degrees. So if you see this technique, along with radio frequency, you also combine it with a mechanical removal by using this ronger. So it is a small forceps which you put through the cannula, and you can mechanically remove the disc material. So basically what you are trying to do is whatever degenerated material is there, you remove that, trying to ablate the tissue and also shrink the nucleus. So there are three mechanisms which are being used in a single technique. And also you can see the what you are doing, you see under direct endoscopy control. So this is which is very, very important, and many times we don't use endoscope, we directly do under fluoroscope and do the things, but you have option of putting endoscope, see what is happening, what is before and what you have removed, how much you have removed, everything you can see, right? And why we have to remove the nucleus, why you have to decompress the disc. It is important because many times we have, because of the compression, we have venous stasis. So venous stasis can cause compression on the blood supply of the nerve, and it is very important that you reduce the venous stasis, improve the metabolism of the nerve, and improve the the condition of the nerve. So you can see this is before you can see the canal diameter, intervertebral foramen before the decompression and after the decompression. This is the cadaver picture. So you can definitely improve the foramen size, reduce the venous stasis, and improve the nerve metabolism. So same. So basically where we use this, it is very important to finalize what are the patients you are going to treat with this. And few patients we treat is contained disc herniation. By meaning contained, we know that it is the annulus fibrosis is not broken up, the nucleus is not leaking out. If it is leaking out, that means even if you are doing decompression, you are not going to achieve the desired effect, and this is not the technique for that. Symptomatic protrusions, of course, on MRI, if you see a protrusion which is not leaking, you can do it. And advanced degeneration with obvious intervertebral pain. By meaning by obvious intervertebral pain, I mean when you are doing discography, you have to reproduce the same pain, concordant pain in the same area. When you are injecting a dye, patient has to tell me, oh, I have pain here, same area where I had, and it is 10 out of 10 or 9 out of 10. So this is the important thing when we do this procedure, that we do discography before procedure, and then we decide to do this treatment. Always we do this treatment after doing interventions which are less invasive. We do medical management, physiotherapy. We give them rest for a certain time. We try to avoid the things which are causing the pain, and also we do epidural injections sometime. Whatever possible, less minimally invasive things before we go for this, because it is a procedure in the disc, and we consider disc as a temple, and we don't want to enter the disc without seeing that other less minimal invasive techniques are effective. So these are the two things we use. One is disc FX, and the similar thing which is extension of disc FX is endoscopic discectomy. So I'm going to talk about disc FX. So these are the some of the pictures where we do it. I already told you, but we don't do in extruded disc, canal stenosis, multiple disc prolapse, very bad canal. We don't do it. So this is a system where we have steerable probe, which is called trigger flex or disc FX. And these are the different cannulas with a dilator. We put a guide wire first, then dilator, and then we put this probe inside. And this is the radio frequency probe. And this is a ronger, which is you can open inside and remove the disc prolapse. And this is a small endoscope which is inside. Now, we always do it is the patient is under sedation, a little bit sedation and local anesthesia. There is no general anesthesia given. We have to put the patient in prone position with a bolster below. The abdomen should be free, so there is no pressure or no increased bleeding because of the venous stasis or pressure on the major arteries. So we always do it in AP and lateral position. So basically, you have to put markings on the skin after seeing the X-rays. So basically, you have to put a spinous line. Okay. Second is you have to decide the level at which you want to enter. It may be L4-5, L5-S1. Many times L5-S1, the iliac crest is coming in between. It is a far lateral technique. It is not like epidural injection where you go just lateral to the midline. You have to go almost 8 to 10 centimeter lateral to the midline. So you have to decide the level you have to enter. You make a perpendicular line to your interspinous line, and then if you are doing at L5-S1, you have to adjust the line, lateral line, above the iliac crest. So you have to enter somewhere here. So once you put these lines, first line, interspinous line, second line at the vertebral level or the disc level, sorry, not vertebral level, disc level, and third line we put on the lateral side. Patient in prone position, with a metal marker, we take the anteriormost part of the border of the vertebra or disc, and we make a line up to the skin, posterior part of the skin. So this line, when it is crossing the lateral, this line, at that point the crossing is marked, and that is the entry point for the disc. So that there is where we give local anesthesia. Usually this line corresponds to 9 to 12 centimeter. More fatty the patient, you have to change the direction. So after you do these markings, you have to also decide what is the protrusion, whether it is a central protrusion, whether it is a or it is in the foramen. Depending upon that, you have to adjust your needle direction. So when you are in foramen, you have to go little bit more obtuse. So it is not steep, it is little bit less, more degrees. So these are the markings which are done for L5-S1. So this is the intervertebral disc line, and we have adjusted this line so that we can go above the iliac crest. So this is the guide wire we have passed through this. Okay, this is the around 8 to 10 centimeter. So I'll just show you some X-rays with a diagrammatic presentation how the needle goes inside. So basically you have to do two views you have to take for every point. So once you insert a needle, you have to check in AP and lateral both. So once you put your needle from lateral, you have to see the distance from the facet joint how far your needle tip is there. And same thing you have to see in the lateral. Both the things should correspond to each other. Because if you are in lateral, if you are going too deep, that means you might be little posterior. So you have to adjust your needle trajectory so that you are going little bit towards the disc in the Cambion triangle. So once you see this, you can see the needle is going nicely inside. The important thing here, you don't have to enter the needle in the middle part of the disc. In the lateral position, it should be in the posterior or dorsal part of the disc. That is where most of the protrusion, most of the inflammation, most of the new neurovascular bundles are forming. That is where the pathologic zone. You don't want to do anything here in the middle part or in the anterior part. You want to do everything in the posterior part of the disc. That is what we see in MRI. This is the posterior protrusion. Usually we don't want to treat anterior or middle protrusion. So in the AP view, it is in the interspinal line, and in lateral view, you have to be in the posterior part. And that is where you want to remove whatever you want to do it. You put a dye, see the disc, it should not be leaking in the canal. Then you have to put a dilator. Through the dilator, over the dilator, you put a cannula, and then you put your steerable, the ronger. Then you do a debulking, and once you do debulking, see, all the debulking, what we are doing, it is happening in the posterior part of the disc. That's the advantage of putting the needle through the far lateral position. And then once you do it, you connect your steerable, cannula to the disc to the eloquence generator. And then you use both the mode, turbo mode and hemo mode, to do a coagulation of the nucleus and to do a neuromodulation of the annulus. So we have treated around 25 patients from February 2014, and the inclusion criteria, I already told you, exclusion criteria I told you. We had 16 male, 9 females, average age was 38. The average preoperative visual analog scale was 8. Radicular component, everyone had radicular component in the leg in L4 or L5. Everyone had back pain. So we treated all these patients. At 2 weeks, the average visual analog scale was 6. It was reduced marginally because most of the complications are usually post-op back pain, and most of patients had back pain. In 4 weeks, 3 patients, 3 VAS was 3, 3 months it was 3, 6 months 3. In this, out of 25, 2 patients went for percutaneous endoscopic, transfemoral endoscopic discectomy, and 1 patient had to go for, after 6 months, because pain recurred and he was not happy with the procedure, he had to go for surgery. So the results, radicular pain reduced in all the patients significantly. Back pain was annoying complaint at up to 3 to 4 weeks post-procedure in most of the patient, and 4 to 6 week duration with significant pain relief with all symptoms. So conclusion, we have to use this technique in select patients. Good clinical diagnosis is important. Good MRI reading is important. We have to know the needle trajectory. We have to decide the level at which we want to enter after doing a good discography, and we have to do after conservative management is failed. And we have to remember that critical complications can happen when you are entering the disc. So you have to take aseptic precautions, and with that, I end my lecture. Thank you very much. Thank you for your patient hearing. Okay.
Hello. All right, we can get one question because he has actually 2 minutes left. So if anybody has a question for him.
Is anybody using DisFX here?
I do
Yes,
a lot
sir.
of endoscopic spine, so I use, I guess a couple of points. I do a lot of endoscopic surgery. I've been doing it for about 10 years.
Yes.
The Disc FX is, Eloquence is actually a subsidiary of Elman, and it's very helpful. We use it on minimally invasive procedures using scopes. I think the take-home point here is very important, that for contained disc herniations, there was a couple of studies that came out of Stanford a good 10, 12 years ago, when there was a huge interest in doing nucleoplasty.
Right.
And they found that a small decrease in intradiscal volume transferred to a very large decrease in intradiscal pressure.
Right.
So part of what you're doing here when you debulk the disc centrally or even posterior-centrally, you're significantly reducing the pressure. The herniation hopefully sucks in. There's a little bit less pressure. A terrific minimally invasive procedure for contained herniations. I think when you get to disc extrusions or even sequestrations, obviously a much better way to go is the endoscopic discectomy.
100%. I agree.
But this is a great thing to use in an armamentarium. And if there are guys who are comfortable doing discography and you're looking to step up your practice to the next available procedure, this is the one.
Perfect. Yeah.
So,
Agree.
it's along the lines with nucleoplasty. It's a very small needle if you don't want to go endoscopically.
Yeah.
And it's very similar to a discography approach. That's all. Great discussion.
Thank you. Thank you for your inputs. Thank you.
Talk about the mechanism underlying the transition from acute to chronic pain. You already upload?
It's okay.
Which one?
It's this one. Right, thank you. Ooh, where is the laser pointer? Yeah. Oh, it's yours. Okay, it's not for everyone. Thank you. Okay, great. So, good morning, everyone. Thank you for inviting me to speak here. It's a great pleasure to share our research data with you. The title of my talk is Facilitating EP4 Export and Synthesis is a novel mechanism underlying PGE2-induced low-receptor sensitization. Pain is an unpleasant sensation. Physiological pain plays a warning and protective role for maintaining our tissue integrity. However, pathological pain is by nature a kind of disease. It includes inflammatory pain and neuropathic pain. Inflammatory pain is caused by injury or inflammation in tissue. Neuropathic pain is caused by injury or disease of the nervous system, mediating pain transmission and perception. Based on duration, pain can be divided into acute pain and chronic pain. Acute pain lasts less than 1 month, and chronic pain lasts months, years, and a lifetime. Actually, you know better than me for this. So chronic pain is a serious clinical concern which affects more than 20% of the world population and incurs worst quality. It cost to Canadian society is $37 per year, more than cancer, heart disease, and HIV combined. Persistent inflammation pain and neuropathic pain are pain conditions. Treatment of chronic pain is frequently unsatisfactory due to unclear key mechanisms. Over the past 2 decades, accumulating evidence suggests that long-lasting sensitization of neurons along pain transmission pathway contribute to the genesis of chronic pain. The sensitization of neurons along the pain pathway is caused by their myoadaptive neuron plasticity. And the inflammatory mediators is a major driving force of the sensitization. When the tissue is injured, inflammatory mediators were produced and released by infiltrating inflammatory cells. These inflammatory mediators include cytokine, chemokine, neurotrophin, peptides, lipid mediators, and they can excite the free nerve ending of nociceptor to cause sensitization of dorsal root ganglion neuron, and also called peripheral sensitization. And sensitized DRG neuron can release a huge amount of pain mediators or pain transmitters into spinal dorsal horn to sensitize the secondary relay neuron there, and also activate glial cells. Glial cells that continuing to release a wide range of pain mediator and build up, wide up there. So enhanced pain signal further transmitted to the higher brain regions, mediating pain transmission and perception, so to cause the sensitization, central sensitization. So therefore, peripheral sensitization and central sensitization together underlie hyperalgesia and anhedonia. The symptoms commonly seen in chronic pain conditions. We are more interested in one of the well-known pain mediator, prostaglandin E2, PGE2. PGE2 is abundantly produced by inflammatory, by infiltrating inflammatory cells, such as macrophage, also produced by local cells. So PGE2 can directly sensitize those receptors at different levels, for example, functional, transcriptional, and translational levels, and cause the DRG neuron to sensitize for long term. So as DRG will release glutamate, substance P, CGRP, BDNF, these PEN transmitters or modulators into spinal to sensitize neurons there. Therefore, PGE2 not only play an important role in peripheral sensitization, also play a role in central sensitization in the dorsal horn. So, the sensitizing effects of PGE2 and those receptors is mediated through its 4 EP receptors, EP1 and EP4 to EP4. So we are more the 4 EP receptors that are coupled to different G proteins and trigger different signaling transduction pathway. We are more interested in one of the subtype of EP4 receptors. EP receptors, it's EP4, which can couples to GS protein and increase intracellular CAMP level and to activate PKA and EPAC signaling transduction pathways. This is quite well documented. So the acute effects of PGE2 and those receptors has been well documented, such as increase the ion channel, like a sodium calcium channel, and reduce potassium channel, and also increase TRPV1 currents in DRG neurons, and increase release of glutamate, substance P, and CGRP, and potentiates sensitizing effects of other PEN mediators, such as capsaicin, ATP, bradykinin, and so on. So this has been well documented in literature. Over the past several years, we and others found that PGE2 also causes the chronic effect, sensitizing effects on those receptors. For example, we found that PGE2 can increase or stimulate the synthesis of TRPV1, sodium channel 1.8, substance P, CGRP, NGF, BDNF, and interleukin-6 in DRG neurons. So these chronic effects has a more significant effects in the sensitization of those receptors. We found that EP4 play a major role in the chronic sensitizing effects of PGE2 in naive, in DRG neuron of naive rats. The EP4 is only expressed in small size DRG neurons. After nerve injury, it's upregulated in DRG neuron, not only in small size, but also in medium and large size DRG neurons. After inflammation, the EP4 also upregulated in DRG neuron. However, it's unclear if the expression of EP4 has been shifted to the medium and large size populations. So in our pilot study, we found that under normal condition, PGE2 is localized in Golgi apparatus in paranuclear regions. However, following PGE2 treatment, the expression of PGE2 distributed to the more peripheral regions in the cytoplasm. So we thought likely PGE2 could stimulate the cell surface trafficking of EP4. Therefore, we raised the question, why the PGE2 stimulates EP4 externalization in a positive forward manner? And the second question, whether this event contributes to PGE2-induced receptor sensitization. Using antibody feeding-based externalization assay in the cultured DRG neuron, we found that PGE2 concentration dependently increased EP4 cell surface abundance. So this duration treatment is, we found the optimum time is 1 hour treatment. That causes the maximum or plateau effect of externalization. And we also found the EP4 agonist also increased EP4 surface density, but EP4 antagonist suppressed PGE2 induced effect. So suggesting that EP4 activation is required for PGE2 induced EP4 cell surface trafficking. We also found that inhibitors of anterograde transporter, BFA, and the protein synthesis inhibitor also suppressed PGE2 induced EP4 surface trafficking, indicating PGE2 not only mobilize EP4 stored in Golgi apparatus, also stimulate the synthesis of EP4. So we first found that inhibitors, PKA, PKC, and PKC epsilon can attenuate EP4 agonist-induced EP4 externalization, suggesting that CMP-PKA signaling and PKC-PKC epsilon signaling are involved in this effect. So next we ask whether PGE2 EP4 cell surface trafficking is coupled with EP4 sensitivity in DRG neuron. We used two markers. We know that EP4 is coupled to G protein, GS protein, and increased intracellular CMP level. So CMP level we used as a marker to indicate EP4 activity. And another indicator is CGRP release, because EP4 is involved in PGE2-induced peptide release. So we found that when we gave the double exposure of EP4 agonist, for example, we give the first EP4 agonist, and 2 days later we give the second exposure. We found the double exposure significantly induce a great CMP level, and also induce a great increase in CGRP release than a single exposure. And then when we give the inhibitor of anterograde transporter with the first exposure, we found this effect has been blocked. So suggesting that the first exposure increased EP4 cell surface trafficking. Therefore, when the cell exposed to the second exposure, second EP4 agonist, it will induce great increase in level and CGRP release. So indicating that EP4 activity, increased EP4 cell surface trafficking is coupled with enhanced EP4 activity. So in the in vivo studies, we give intraplantar injection of inflammasome CFA is complete fluid adjuvant. We found that this treatment increased EP4 levels at a cell surface as well as in cytoplasm of epizolateral DRG neurons. Interestingly, when the CFA was co-injected with a COX-2 inhibitor or EP4 antagonist, we found increased cell surface level EP4, and also the cytoplasm level EP4 has been attenuated, suggesting that PGE2 EP4 signaling in inflamed tissue can stimulate the EP4 synthesis or cell surface trafficking. So summary of part 1, PGE2 EP4 signaling facilitates EP4 cell surface trafficking in cultured DRG neurons. CMP, PKA, and PKC signaling pathway contributed to PGE2-induced EP4 externalization. PGE2-induced EP4 export is coupled to enhanced EP4 sensitivity, therefore sensitizing nociceptors. PGE2 EP4 signaling in inflamed tissue increase EP4 cells in DRG neurons. Taken together, facilitating EP4 cell surface trafficking is a novel mechanism underlying PGE2-induced nociceptor sensitization. So the question 2 is whether PGE2 stimulates EP4 synthesis and axonal trafficking in DRG neuron in a positive manner, and whether this event contributes to transition from acute to chronic pain. We used a model, transition model. It has been found 10 years ago that a single intraplantar injection PGE2, the pain, evoked pain only lasted for 2 hours. However, when previously given the rat injection of carrageenan, interleukin-6, or exposure animals to stressful environment, 1 week later, give the intraplantar injection of PGE2, invoked pain can last for more than 24 hours. This phenomenon has been called as hyperalgesic priming, or we call it prolonged sensitization pain. It's a widely used preclinical model for transition from acute to chronic pain. So we used a stabilized PGE2 analog, DMPGE2. We gave the injection. We found the compound can cause pain for 1 day or 24 hours. And then 1 week later, we give the second dose of injection. This time, we found the evoked pain can last for 4 days. When we gave the EP4 antagonist with the first injection 1 week ago, we found this treatment blocked the prolongation of pain caused by the second dose of DMPGE2, suggesting that EP4 is involved in the prolonged sensitization pain. So when you see, we give the first injection, the pain lasts for 1 day. Second injection, the pain lasts for 4 days. And then we give third injection, the pain lasts for 11 days. We give the fourth injection, the pain prolonged to 31 days. So indicating multiple sequential injection of DMPGE2 progressively prolonged tactile anhedonia. So when we give the pre-injection of the inhibitors CMP and PKA with the first DMPGE2, this treatment blocked the prolongation of pain evoked by the second DMPGE2. When we gave the injection of the inhibitor PKC and the PKC epsilon with the first DMPGE2, we found this treatment blocked the prolongation of pain evoked by the second DMPGE2, suggesting CMP, PKA, and the PKC epsilon signaling involved in the prolonged sensitization pain. So we also gave the co-injection of COX-2 inhibitor or EP4 antagonist with 2 inflammagens. First is carrageenan, and the second is CFA. Carrageenan usually causes pain for 1 day or 3 days. And 1 week later, we gave the injection DMPGE2. We found the pain, the prolonged sensitization pain has been prevented. And the CFA caused pain for last month. And 1 month later, we gave introplantar DMPGE2, we found the pain lasted for more than 5 days. However, when previously injected with a COX-2 inhibitor or EP4 antagonist, the prolongation of sensitization pain has been shortened. So we found that a single introplantar DMPGE injection induced a delayed and prolonged EP4 upregulation in DRG and the sciatic nerve, suggesting that PGE2 can increase the synthesis of EP4 in DRG and axonal in the peripheral nerves. So we gave the double injection, sequential double injection of DMPGE2. We found that treatment induced much higher level of EP4 in DRG neuron than just a single injection. So summary of part 2, repeatedly sequential exposures PGE2 progressively prolonged sensitization pain. Activation EP4, CMP, PKA, PKC epsilon signaling pathway is involved in this event.
PGE2 EP4 signaling in inflamed tissue sensitizes the receptor to subsequent challenge or pain mediators. EP4 upregulation in DRG neuron is possibly a key event in prolonged sensitization pain and transition from acute to chronic pain. So conclusion is EP4 signaling in inflamed tissue stimulates synthesis, cell surface trafficking EP4 in DRG neuron in a positive forward approach. And PGE2 EP4 signaling induces EP4 synthesis and cell surface trafficking is coupled to enhanced EP4 activity and receptor sensitization. Facilitating EP4 synthesis and cell surface trafficking is a novel mechanism underlying PGE2 prolonged receptor sensitization. Transition from acute to chronic pain. Future direction, does prolonged sensitization pain occur in mice with EP4 conditional deletion in DRG neurons? Can EP4 receptor antagonists reverse established prolonged sensitization pain? Is stress hormone cortisol able to stimulate EP4 upregulation in DRG neuron? Is PGE2 induced EP4 synthesis and epigenetic modulation? So this study is done majorly by my research assistant, Bruno Senjaki. Other students also contributed to this. Supported by Canadian Institute of Health Research, National Science Engineering Research Council of Canada, also supported by Alan Edward, Penn Research Foundation at McGill University. Thank you for your attention.
We are out of time here, so we'll have to move to the next speaker.
Okay.
Basically, I'm going to drag you through here many things. It's a kind of provocative. I would like to thank you for inviting me here. I would like to thank you for inviting me here, and my name is Dr. Ziad Al-Shami, Director of Pain in Saudi Arabia. I'm a neurologist by training and pain specialist. What I'm going to do here, I'm going to be a little bit provocative, and I'm going to put things together with the pain. Hal yesterday put us all the other speaker in the morning, she put us all in the trigger point areas where the muscles are. And fibromyalgia put us where? Other pain put us where? Neuropathic pain put us where? If I have a human being, a body, that is, part of it is a skeletal, that has neurological distribution with radicular distribution, with muscular entities that are up the neck, up the shoulder, down to the buttock area, surrounding and hugging the head in the middle, where the neck starts, by the eyes, by the ears, where the nerves and the muscles and all the entities come together, facet and muscles, disc and nerves, bulging and changes, referred pain everywhere, headache is intermingled with radiculopathy, with referred pain. It's a truth. There is a referred pain, there is radiculopathy, there is injury, there is inflammation, there is injections that relieve that, there are the changes that happen, and there is a continuity of care that could interact with things. We decrease the disc, the size disc, we relieve radicular pain. Changes, there's inflammatory. The head is hugging with the rest of the body, and there's inflammation, local inflammation and central inflammation, and there's localization that happened. Where's migraine and where's headache? And what is headache that's associated to cervical component? And how does the neurological distribution and the radicular distribution, and where is the scoliosis? And what's happening? The fascia is restraining and restricting the spine, or the spine is intermingling with the rest of the muscular entity and making trigger points. And these are trigger points that had inflammation in them, that is pouring with the changes. There's inflammatory and immunologic and intermingling all the way, ascending and descending pathways. And these joints that intermingle and has tendons and has a lot of entities and joint spaces and others. Where is the receptors? Where is the nociceptor? Where are the neuropathic changes? And how does all of that intermingle? When I talk about entities, like we're going to talk about in a little bit about fibromyalgia, how is that happening, and how is the joint, and how is the joint bulk, and how is the compartment syndrome, and how is all of that relate to different symptoms that comes, and why do I have distributions in fibromyalgia, and where the pain is coming from, and how would innovative techniques like shock waves work? How would energy does the changes? How can I pour energy with the frequencies and help change the vascularization and rebuild the system and rebuild the changes and work as a trigger like other things, and how would other things like laser therapy and other also create similar injury? Fibromyalgia, they tell you would have a middle-aged woman that's going to have injury. These injury going to start peripherally. They're going to be changes. They're going to be calcium influx. They're going to be an inflammation. Inflammation going to go up the sensitization we all agreed about. And going to make a difference. Start peripherally, ended up centrally, made central sensitization, amplified. It's amplification of pain. It's amplification of symptoms. They have lower threshold for pain, and they have an amplified, exaggerated symptoms. It comes to the brain. It makes a pain in the brain. Pain in the brain is a reality. Why? Because there's functional MRIs, and there's exaggerated changes that happen, and it comes all the way up and upregulated, and we see the changes. And if we look at the different thresholds and the different changes that happen, and we look at the functional MRI, and we link that to markers, substance P, glutamate, changes. Look at it in the cerebral spinal fluid. See the increase that happens simultaneously in fibromyalgia patients, and as per a study that were denoted, link it to central sensitization, and look at substance P, and look at others, and link the changes. Link it to my patient comes out the door, and she has a multi-system symptoms. She has a combination. She hit herself. She had a complication of left-sided neck pain, upper back, lower back, in between shoulder changes, joint diseases, elbows, knees, and other psychological symptoms, GI symptoms, genitourinary symptoms, parasympathetic changes, and so forth. And she comes and tells you, well, this is my story, and this is my changes, and this is what's happening. Where am I? Am I a rheumatology case? Am I an immunology case? Am I an inflammatory case? Am I a psych case? I'm stranded. I don't know what to do. I can't move my neck like they said in the morning. I can't do anything. And you look and evaluate. Look, the average age of women that they're stuck at that age, they're mostly female. Why? And you look at the history. There are always, in our eyes, criminals. Somatization disorder, anxious, crazy, depressed, crazy woman. I don't want her in my door. I don't want her at my door. And you look at the pathophysiology, and you link it, and you look at the neuroendocrine axis. You sleep cycles. You see the changes, the growth hormone, the insulin, the growth hormone, and the REM sleep and the non-REM sleep changes in stage 3 and stage 4 and other. And you evaluate this insulin and see how that is changing with the rest of the sleep cycle. And again at substance P, and again at others. And you go back to your presenting complaint, and you link it, and you put all of this together with your entity, and go back again. Fibromyalgia cycle of illness, disturbed sleep, depression, pain, inactivity. Why? Why is she exhausted? Why is she fatigued? Why is she tired? Why is my processor, if I fry it, it will be giving me trouble advancing my slide because it's overcooked? And this is how all these changes. Why do I have a swollen feeling like joint without being swollen? Why do I have these subjective changes with some different vague pain? Where the headache and migraine come from, where the dizziness come from, and so forth. So basically, there've been a lot of evaluation and classification where they say these people have trigger points. Most of the trigger points are in the upper trunk, lower trunk. They have to be up and down. They have to be more than 3 months. They have to be linked to multi-system, including sleeping disorder, GI symptoms, genitourinary symptoms, and you have to look at the triggers. You have to look at the sternocleidomastoid. You have to look at the occiput. You have to look at the second rib. You have to look at the elbow. You have to look at the buttock. You have to look at the knees, and you have to link all of that together. There's a scoring, WPI and SS scale, and there is form to put it, and there is differential diagnosis. UNIT is a differential diagnosis of exclusion. You cannot say somebody has 5 until you make sure they're not what? They're not diabetic, they're not inflamed, CRP, and TSH, and lupus, polymyalgia rheumatica, and all of that. So, no autoimmune, no inflammatory process, no endocrine issues, no vitamin deficiencies, and so forth. And once you come to that realization, then you are stuck, because you're stuck with a fibromyalgia patient. And how can we gonna address that? Is that a reality? Yeah. Oh, it's not a myofascial pain. No, it's not. Because the pain is spread everywhere, and the myofascial pain is more axial in the middle of that. Could be a chronic fatigue syndrome because she has and so forth. No, it's not a chronic fatigue syndrome because she doesn't have a fever, and she had other neuropathy, and she doesn't have other issues. What can I do? I have to throw something in. Why does she have a comorbid conditions? Why does she have a migraine? Why does she have a chronic headache? Why does she have irritable bowel syndrome and dysmenorrhea and depression? She's crazy and TMG. Because of a centralized, peripheral, centralized process that has included different areas in the brain, and it's a fact. Oh my goodness, how can we prove that? I have fibromyalgia, so I have a combination of entities that are working together. I have central, I have eyes, I have muscular, I have joints, I have urinary, and this is me. There is intermingling neuronal changes with inflammatory process and other entities that are happening, overloading the brain. Brain is being cooked, and when the brain is cooked, a lot of changes. Do I look at the brain and I ignore totally the peripheral part? No. I start at my muscle fiber, I look at my fascia, I look at my nerves, I look at my entity, I look to the trigger point, I know there is an inflammation, I know there is a coded changes that is linked to the water processor in the brain, that everything is coded and intermingling together and changing. And I remember that there is something called nowadays functional MRI that shows changes relevant. Very elegantly, my partner today, a physical therapist, went over how the emotional changes encoded with the pain changes, peripherally and centrally, and they're all in the functional MRI are coded. Trigger point would work. Hal yesterday was a gentleman that pokes that dry needles. I think he's right. I think my colleague, the physical therapist this morning, is right about the dry needling and about making a disruption in the inflammatory and other changes. So basically, when I look about a machine with called extracorporeal shockwave, which works with high energy, which has a focal head and a radial head, the radial head spread over the muscle fiber, take away the trigger point changes, take away this nothing that go back, and re-straighten the structure of the thing, and the focal head goes away and pump in energy and frequency, and does changes that all the way shifted from my peripheral nerves, neurons intermingling all the way through the dorsal horn, all the way up the thalamus, all the way to the sensory cortex, and making changes. This is why when I have FDA indication approved for extracorporeal shockwave for plantar fasciitis, for tennis elbow, and for other that make sense. When I remember the pictures I showed at the beginning where we have a muscle and a fiber and a tendon and a sheath and a fascia, and all of these are encoded in the brain and going up. Look at this focal head, and look how this focal head is working and putting the pressure and putting the energy deep inside. There's a studies about plantar fasciitis that has proven this energy, frequency, number of shots related to revascularization, to rebuilding the area, to show changes that happen accordingly with this. So basically, there is also studies about myofascial pain and trigger pain. By massaging them, not only by just doing shockwave, by massaging them alone, we could do changes and result in things. I did not want to start in fibromyalgia. I took the radial back in 2010. And earlier, I started doing this since 2006. I went to Germany. I got the machine available in Saudi Arabia. I believed in the machine. I got the radial, and we started working with the trigger point. It worked. And then I went, and I started going where my patient going. My patient have cervical issues, lots of cervical issues, especially with now careers, with headache and others. So we looked at the cervical headache, we looked at this trigger point, and we started linking these together, and we have done a study that showed it works. Then we went to another area with my focal head, and I looked at the lower back, and we worked the focal head, and we've worked from a location from L1 to S1 and L4, 5, S1, and we have seen good, excellent result that exceeds 65% in so many cases. And then we said, why don't we compare that to Botox? I mean, why don't I apply the Botox? And I had an interesting discussion, me and Hal, about applying that in compartment syndrome, or whatever you want to call it. And comparing it to Botox, shown that they could have a combined, well-combined effect. At the end, I said, let me go and try it with fibromyalgia. So what we've done, we evaluated the patient. We made sure they're not psych. We made sure, it's very hard in fibromyalgia to say they're not psych, but I made sure they're not really psych. And I made sure that, it's pain. It's a pain syndrome. And I made sure we don't have any organic issues. We did all of that. And then we mapped their area. And we worked in the projects areas above or below the line, and we have compared that with 12 session, and we've seen the progress going to 70 and 80%, and it does work. Do I want to do a more retrospective blended study at one point? Yes, I want to do that. I looked at all the literature. I mean, there's nothing about extracorporeal shockwave except for plantar fasciitis. It is very limited, and I think we need to publish about that. I would like to thank you very much for tolerating me for the last 20 minutes.
All right. He does have a few minutes left. With anybody like? Okay, here we go.
So I'm also a huge proponent of EPAT. I've been using it for about 5 or 6 years. A couple of questions. And I've used it a lot on tendons and muscles as well. With respect to fibromyalgia, if you're running one area 3,500 pulses at a time, how many total body pulses are you doing in a session? Because theoretically, we are going to break down muscle tissue to some degree, and we don't want to end up with myoglobinuria or rhabdomyolysis. So are you limiting your treatments to a certain amount of total pulses?
Up to 2,000, 2,500.
2,500. So that's really low. You can go higher than that.
Yeah.
Yeah, you can go higher than that.
Because as I said, I take it as a project. I take an area at a time, and I spread them. 6 sessions for this, 3 sessions for this, 3 sessions for this. Give them a break between that, reevaluate, and give them some hydrotherapy in between. Give them some massage therapy in between. Send them to the dry needle in between. And while I'm doing some other, basic treatment. So basically, I, do more than one modality, but some of the areas where I'm working at, it is only shockwave. I don't use massage and shockwave in the same area,
Okay, and you're stopping all the COX-2s and the NSAIDs concurrently for it. This is essentially a pro-inflammatant, so any anti-inflammatories will work against it.
Yeah.
Good.
Any other questions?
How frequent would you see the patient? How frequent the sessions are, and how many sessions would you consider for a fibromyalgia patient at a time?
Fibromyalgia, are you talking about diagnosis and clinical evaluation and then the plan, or are you talking about shockwave therapy?
The shock therapy.
Shockwave therapy is about half an hour, okay? 20 minutes to half an hour, depending on what we're doing, how often we do it. We do 6 to 9 to 12 sessions. We evaluate. We put 3 at a time sometime. We separate them like twice a week or whatever it is. And I stop for 4 to 6 weeks and we evaluate where it's a washout time. I don't do anything. I stop. They do well. And some of these patients, I kept them out of my door for 4 and 5 years. And I thought they gave up on me. They came back asking for shockwave therapy. And, I don't have any stocks in it. But this is honest truth.
And do you have a percentage of the pain relief in average after the
pain
shockwave
relief
therapy?
in average, you're talking at least about 60%. Okay? Thank you.
All right, thank you very much for inviting again. And basically this talk is a very basic talk which all pain physicians they do in cervical area, and it's about radio frequency ablation for medial branch block. Basically a patient with neck pain, they present with localized neck pain, non-radiating stiffness. Morning stiffness is very bad, They usually get better with heating pads and activities. There is intermittent flare-up. Many people, they can have pain going to the neck and shoulder, and sometime to the head. So cervicogenic headache is another entity where we can use this modality. And usually pain can be unilateral or bilateral. Upper cervical joint causes not only back pain, neck pain, but also headache and cutaneous pains. This is very, very interesting to see in our country, that we see patients where they have a lot of burning pain, they have a different kind of sensation over the eye, over the jaw, and they complain. If you take history properly, the patient tells that pain starts here and then it goes everywhere. And sometimes it is reverse also. So you have to, and they have taken a lot of treatment and they come to us, and we have to really make sure that it is causing, the cause is coming from neck. So once we know that, then we can go for diagnostic block and do the radio frequency. But it is interesting to see these patients. Some patients have tingling also in the facial or in frontal area. So the pain frequently referred to the shoulder girdle, and it is extend to the elbow, and rarely distal to the elbow. But we have seen patients all the way. It's not in the radicular pattern. It's a vague pain which is going all the way to the hand also, sometimes tingling and all. And they have severe weakness in the, not severe, but they have weakness in the grip also. But all the neurological testing, EMG, everything comes normal, and you do diagnostic block, and they feel completely okay. So few patients we have seen like that. It is not very common, but I'm just mentioning that these are the kind of patient we see there. So pain should not follow a radicular pattern. So this is the main thing, because if it is radicular pattern, then it goes more in favor of the nerve root pain. So this is a very famous diagram, how the pain distribution among different joints. You have C2, 3 coming in the upper part of the neck, sometime to the head, C3, 4 in the middle part of the neck, and C5, 6 to the scapular area and to the shoulder girdle, and C6, 7 all the way in the mid back. So we normally palpate the patient, palpate the patient's neck, and we believe that it's mainly a clinical diagnosis, and many times the radiological investigations do not help us. So we have these patients with the normal power, normal range of movement, not normal, but it's a limited range of movement of the neck. Mainly in the extension, they feel pain, and there's a tenderness over the facet joint. That's a paraspinal area, and local tenderness over the facet joints. So to rule out different problems like herniated disc or any other problem in the neck, like cervical myelopathy or cervical tumor, sometimes we investigate this patient, and in older patients we have diagnosed some patient with a metastasis or carcinoma also. So you have to rule out other problems when you are dealing with older patients. So X-ray, CT scan, MRI, bone SPECT, all these things as per requirement, as per the patient profile, we have to do. And as I told you, it's more of a clinical diagnosis. So basically, once you take a history, you do physical examination, and then you do a radiological test, you decide that the patient is not having any other organic problem, and then you clinically are sure that this patient may have medial the facet joint problem in the cervical area. Then the gold standard for diagnosing and to confirm the pain generator coming from the neck is a medial branch block. So basically you do a diagnostic medial branch block. Normally we do under fluoroscopy guidance, either in supine position, prone position, or lateral position, all these things. So if you see the anatomy, it's very simple. We almost be knowing about it, but we have a dorsal root, dorsal Then we have a medial branch, lateral branch, and the intermediate branch. The medial branch goes to the facet joint mainly, and also supplies some of the small muscle group in the paraspinal area. So medial branch, by blocking it, the idea is to make sure the pain which is coming is blocked by medial branch. If we have that and patient gets more than 80% relief, then we can confirm that patient's pain is pain is carried by the medial branch, and by blocking that for a longer time by using radio frequency, patient will have good relief. So for cervicogenic headache, normally we use C2, 3 and C4. These are the medial branch will block, and all other things as per the diagnostic criteria. As per the diagnostic block, we do a RF ablation at the particular level. So if it's all done in AP and lateral view again, and in AP view, if you see the needle positioning is at the curvature of the facetal pillar, and needle should not cross the medial to the lateral border of the facetal pillar. If you are going medial, then you might be entering the foramen. So that is not good. You can do a damage to the exiting nerve root. So you have to be outside the pillar, as you see in this X-ray. In lateral view, you have to overlap the right and left pillar properly, so that you can see nice border of facetal pillar. You can see nice facet joint at each level, and your needle should enter all the way to the anterior portion, because you want to ablate the maximum length of the nerve which is running along the facetal pillar, and you don't go beyond the anterior border of the facetal pillar, because if you're going anterior to that, in AP your needle will be seen going beyond this point, so you don't want to go there. So this is radiologically, if you want to place your needle, this is the perfect location, paralleling the right and left side of the pillar, and putting the needle in the middle of the facetal pillar. If you're doing diagnostic block, you don't need to go so much beyond. You can just put your tip at the center of the facetal pillar, and you can inject half to 0.75 cc of your local anesthetic. You will get fantastic relief. You can go for radio frequency, and during radio frequency you have to put your needle in this position. So you don't have to actually go in the anterior portion when you are doing diagnostic medial branch block, because the drug can spread 1 to 2 millimeter. But when you are doing radio frequency, it is along the nerve has to be parallel to the shaft of the tip of or a tip of the needle, the shaft of the tip of the needle. So they are parallel to each other, and usually the radio frequency current passes along the shaft, not at the tip. So these are the different points where you have to place your needle at different level. So at C2-3 joint, we also call that medial branch as a third occipital nerve. So this is the area just above the joint, at the joint, and below the joint. There are 3 points we place our needle, and make sure it is coming from down, inferior to superior, and it is placed parallel to the joint line. So the first needle is at the, if you see this foramen, your needle should be at the top of the foramen. Second needle at the facet joint in the middle part of the foramen, parallel at the level of middle part of the foramen, and the lower one is, the third point is lower one. So this is the placement has to be perfect to get the best possible effect. And then for other levels, you have to be in the middle part of the facetal pillar. Again, radiological pictures. You can also do intra-articular injection, which normally I don't do. This is something. But when you are doing intra-articular injection, you have to enter 2 levels below the joint line, because it is superior inferiorly projected. So to enter the joint, you have to go very obliquely and go. You cannot go in end-on view, or you have to place your C-arm chordally, so that your view is along the joint. Cervicogenic headache, you can have pain coming from C1-2 joint also, sometimes C2-3 joint also. So if patient is having severe headache in the occipital area and he has severe pain in the on the movement of the neck, and your medial branch block at C2-3 or C3 or C4-5 level is not relieving his headache, you might consider, and if your CT scan is showing some arthrosis at the C1-2 joint or AA joint, or OA joint, then you can go at that level and you can just inject local anesthetic with steroid and see how much relief he's getting. That's the diagnostic value, but normally we don't do RF ablation at that level. People have tried pulse radio frequency at that level, but in my view, it is not very helpful pulse radio frequency at OA or AA level. But steroid can help in giving a diagnostic value and referring to surgeon for some fusion surgery. So, see, this is the OA joint, the AA joint in lateral view. So basically, I'm not going to detail because it's not a very commonly done procedure in my practice. But mainly we see patients coming because of rheumatoid arthritis or subluxation. You have to remember the neurological sequel if you are going wrong in that area. Normally, you go in the lateral part of the joint and inject your dye and your steroid, and the treatment can be surgical. So you have to refer to surgeon or show surgeon and take opinion whether he can help this patient, and then do diagnostic block. Just doing diagnostic or steroid injection is not going to help the patient for longer duration. So basically, you have to differentiate between what are the joints which are being affected, which are causing pain. So you have to do differentiating block at a different level. Intra-articular injection is the option which is not done by us very commonly, or not done at all. So you have to see how long the pain is relieved after medial branch block. In India, we have a lot of patients who gets maybe placebo or whatever, I don't know, but after 1 or 2 diagnostic block, they have relief for 6 months. So in many patients, we don't go for RF ablation at all. So by doing 1 or 2 diagnostic block, and if you are getting good relief, we don't go for the RF ablation. So it's a very good number we are seeing in our country. So it's very important to do that and wait for pain to return back. If pain is not returning, there's no point in doing RF. And all these patients are put on physiotherapy. All right. So each patient is good candidate for radiofrequency. We have to see whether proper block is given or not. Before we inject a local anesthetic, we always inject a dye, so to make sure that our drug is not going in the vascular area. Because if you are injecting 0.5 or 0.75 ml of dye of local anesthetic, and we are not injecting dye, okay, so it can be going in vascular space, and when local anesthetic is going in vascular space, you may get a false negative result. So you have to make sure that you inject dye and then inject your local anesthetic to get a proper positive effect or negative effect. So you have to know your drug is in right area and not taken away by the vessels. So in both the blocks, 1 or 2 blocks, whatever we give, you have to have a consistent results, whether you use one drug or you can use 2 drugs. Normally we don't use saline for diagnostic block, and patient should have more than 80% pain relief. That is our criteria. So normally when we do radiofrequency, we put up, we do a radiofrequency ablation at 80 degrees centigrade for 1 to 1.5 minutes, and we always measure the impedance continuously, and we normally do under fluoroscopy guidance. We don't use CT guidance for that. So we have to make sure you are using a right gauge of the needle. You are using curved tip or bevel tip or straight needle. So depending upon that, you have to turn your needle, or you have to take the needle out and go out. If you are using bevel needle, which we are using, if you turn the needle, normally you can move along the larger area. because your area, when you are moving the needle for each lesion, you can cover the larger area. But if you are using straight needle, normally I take out and then place it little up or little down so that you can use a larger area. And normally I use 2 to 3 lesion at each level so that I can get a best possible effect. Stimulation, again, there's a lot of content. We normally use stimulation at each level. We do good motor stimulation and sensory stimulation. We have found, initially we were not doing, because the ICES guideline used to say that you have to place your needle properly so that once your placement is good, anatomically you are in right place, you can get good results. But we had patients where the results were not good. So we have changed our practice to stimulation. If you are not getting good stimulation, then you can reposition your needle. Once you get good stimulation, sensory as well as in motor, as you are getting in lumbar area, the results are much better, much lasting. So you do 1 or 2 to 3 lesion at each level after sensory and motor stimulation. That is our protocol. Pulsed radio frequency, we have stopped doing it. We have used in almost around 50 to 60 patients. We were not happy with the results. Most of the patient comes back after 1 or 2 months, which anyway we are getting this same result with local anesthetic block. So we have stopped using that. So this is the picture where we are using 3 lesion, 2 lesion, and this is normally we are going in the upper area in the facetal pillar at C5, and at C7 we are usually doing at the tip of the superior articular process. So a lot of studies, there is a strong evidence for the short-term relief as per Manchikanti in 2003, moderate evidence for long-term pain relief. Cervical radiofrequency neurotomy reduces central hyperexcitability and improves neck movement in individual by Smith et al., where they have treated 53 patients and they have had sustained pain relief more than 3 months. So all these studies, it is well proven that there is a moderate to strong evidence we have as far as radiofrequency treatment is concerned. So it's a very good tool to treat patients who are having cervicogenic headache, who are having neck pain, not responding to physical therapy or medical management. I think these are a lot of papers are available on cervical radiofrequency ablation. And this is the guidelines 2009. So you can go through this. So already I told you about pulse RF. It's not a good evidence. So facet joint is a clinical diagnosis. We don't depend upon radiological evidences on facet joint, even if they have arthrosis shown in MRI or X-ray. But patient is not having pain, it's no use. So clinically, you have to make sure that it is facet joint pain by doing diagnostic block. RF is proven therapy, and it's a repeatable, very easily repeatable. Thank you very much.
Okay, we have a couple of minutes there. Anybody want to ask a question?
How often do you get a placebo effect
Without
without injecting?
injecting local anesthetic?
You said some patients you just inject the
Yeah.
False positive.
Placebo. See, I think it's a good question, and the same thing people have done with injecting saline. But I normally never. I have not done only just doing needling. If I am feeling that patient is not having facet joint pain, I might do dry needling, as it was told in the morning. And dry needling sometimes gives fantastic effect. And but dry needling, we don't give only one area. We cover the entire trapezius muscle, and that gives very good relief. And we had patient just by dry needling, patient had relief for 6 months. They may not come back if it is a acute or a short-term pain. If it is a long chronic pain, they may come back every 2-3 months, and then we have to repeat the dry needling. But I have not tried just putting the needle over the middle branch and removing it. I have not tried it. Now, what is your experience? I think anybody did that?
Yeah, so the original studies from Lord and Bogduk suggested false positive rates of between 15 and 38%. So a lot of the that do these do sequential blocks, either with longer acting anesthetic or shorter acting anesthetic. So you wanted to see 2 blocks where you get 60 or 70% of relief. Then your false positive rate drops to about 12%.
Yes, that I told
That's
you.
not my studies, that's published.
But I want to emphasize the one point here, that most of the people who do a diagnostic block, they never inject dye there. I recommend putting a small quantity of maybe 1.1 ml or 0.2 ml of dye under live fluoroscopy, and you will be surprised to see that dye is taken away by the blood vessel. It is very, very commonly seen in many patients because all the nerves are along the nerve, there is a vessel. So you have to make sure that your drug is not going in the blood vessel. Then you make sure that patient is not responding, then yes, it is negative. You will not have effect. You will not have effect. Thank you. Thank you very much.
Okay. Good morning, everybody. Distinguished intimate delegates who resisted all the morning to hear what I'm going to say. I'm not going to talk to you about no needles, no shock waves, just what happens between us and our patients. The story started with a guy named Maurizio. He is from Padua, which is in North Italy. In 2008, after a car accident, he takes a CT control for persistent low back pain. And the CT says a large lytic lesion and pathological fracture of L2. In May, in the same year, a second CT control says that the lytic area is unchanged, and the vertebral biopsy allows the diagnosis of Baines-Jones protein multiple myeloma, for which he is now followed by the Institute of Hematology and Medical Oncology of our Bologna University. In May 2009, he gets allogeneic hematopoietic stem cell transplantation from his sister. Unfortunately, in June, a month afterwards, he gets a post-transplantation complication with hemorrhagic cystitis, dermatitis, abundant diarrhea, rectal hemorrhage, and severe gastrointestinal symptoms like nausea, vomiting, and abdominal cramps. What is being diagnosed afterwards as graft versus host disease, stage 4. After several weeks in the hospital, he is discharged, but he is discharged at home with frequent diarrhea episodes, with continuous abdominal cramps and severe pain. He goes home with fentanyl patch, 75 micrograms per hour, with IV morphine, which he receives 3 times a day, with rescue doses of other 2 times a day. Because the patient is intolerant to the IV morphine intermittent injections, it is replaced with continuous morphine through elastomeric pump and afterwards with a PCA device. All this happens outside the region where is our hospital, so we're not aware of all these things. In his hometown, then our colleagues were afraid that he's going to become addicted, so they changed the therapy into methadone, 4 milligrams 3 times a day. Then in September 2009, he's admitted again in the Bologna University Hospital because he had some sepsis related to his central venous catheter. And this is the first time that our inpatient service, pain service, is called to see this patient. What we see is a patient with a persistent abdominal pain with an NRS of 6, with frequent episodes of abdominal cramps of severe intensity, which may rise up to 9, and of viral duration, which is uncontrolled with the therapy, with the ongoing pain therapy. So what we planned at this time, where I ignorant about what we were doing, we gradually proposed to suspend methadone. We give him again the fentanyl patch, 25 micrograms, and we try to titrate this therapy, giving him as rescue dose the possibility to assume morphine orally. 3 weeks later, we see the patient. He says that he is taking the morphine 3-4 times a day. So this, according to our protocol of titration, it means for us that we can increase the patch, and we can now give him the morphine, the oral morphine, not as rescue, not for titration, but as for rescue dose. So this is what we have done. We gave him the 50 micrograms patch, and we let him to take up to 4 times a day, 30 milligrams of morphine orally. But this didn't help him, because when we saw him afterwards in our office, in our outpatient office, he continued to say that his pain, let's call it his background pain, is controlled, but the episodes of intense pain are not controlled. So this is why we decided to stop morphine orally as a rescue dose. We increase the fentanyl patch up to 75 micrograms, and we give him the first time transmucosal fentanyl citrate, 400 micrograms. Because I remembered when I was in Boston in 2002, when I made a 3-month fellowship at the Brigham and Women's Hospital, I saw the first time the lollipop, but we didn't have it in Italy when this case was happening. Anyway, we received for this guy this transmucosal fentanyl, and we gave him 400 micrograms. And it made the change, because the patient told us that he was assuming 4 times a day this fentanyl, transmucosal fentanyl, especially when he was having the diarrhea, and it did cover these episodes. We saw this patient last time in 2012. He was still using only 50 micrograms of patch, and he was using all the time the transmucosal fentanyl 4 times a day. We don't know what happened to him afterwards, because we lost his. So let's make some pharmacological consideration of what was happening with this in this case. Whereas you see, we have a background, what you call a background pain, which was covered by the patch, What we tried at the beginning, because we were ignorant to do, we tried to drown his episodes with increasing doses of fentanyl, of patch fentanyl. Then we gave him the morphine sulfate, orally morphine, for the episodes of intense pain. But as you know, morphine, when you take it orally, it takes 40 minutes to get to onset, and then it lasts for 4 hours. So the episode of intense pain is already gone when the morphine is starting acting. So what you only have is the adverse effect. You don't cover the episode of intense pain, what we call breakthrough pain. So afterwards, when we got a bit smarter, we gave him the transmucosal fentanyl, which has a rapid onset and a short time of action, which is more suitable for this kind of episode. Of course, the ethyl treatment would be a drug which has an immediate onset and a very short time of action. So we revised our attitude towards patients with pain, and as we believe that aside a thorough physical examination, you suppose when where you're doing your diagnosis, you're supposed to define the etiopathogenesis of the disease that the patient have. You have to define the physiopathological mechanisms of pain, which is nociceptive or neuropathic or both of them. Then you have to assess the quantity aspects of the pain. In other words, to measure how intense is the pain, and especially if you talk about chronic pain, you're supposed to use at least a brief pain inventory, because an NRS is not enough, because it will tell you only a very small part of the issue. And then what we found out is that it is extremely important also to assess the temporal aspects of pain, because pain, it's true, may be acute, may be chronic, may be intermittent, but you have to know exactly what is the temporal aspects of your patient's pain. So if you look at chronic pain, basically you can have two types of temporal aspects. You may have the continuous part, a continuous pain on one part, and you can have intermittent pain. But intermittent pain doesn't mean it is breakthrough pain, and you have to know how to select and to understand if it is a breakthrough pain or only intermittent pain. Especially when you talk about intermittent pain, you can this pain may be incident, may be spontaneous, may be mixed, and especially you have to distinguish between a breakthrough pain, intermittent pain, and what you call end of dose pain, which means what happens when you give a pill to a patient, and instead of having its action for 12 hours, for example, if you talk about long release pills, it 10 hours. It means that the patient has metabolized too quickly the drug, and if he has pain after 10 hours, it means it's end of dose failure. It's not a breakthrough pain or intermittent pain. It's just that you have to revise your therapy. Breakthrough pain has a very important clinical burden because, as we know from the literature, it increases depression, anxiety, and health costs. It decreases quality of life, patient satisfaction, and have influence on social relationships, on sleep, on activity, on deambulation, and on work. So it's a very important clinical issue. And our objectives on treating breakthrough pain is to minimize its physical, psychological, and social impact of breakthrough pain, to ensure optimal analgesia while minimizing treatment-related adverse events for both background pain and breakthrough pain, to achieve a rapid control of breakthrough pain, and to use medication with short duration, like I showed you earlier, short duration of action in order to avoid potential accumulation of effects, and of course also to adapt the route of administration. So when we were revising all what our knowledge about breakthrough pain, we were wondering, is breakthrough pain only pertinent to cancer patients, or also chronic pain, non-cancer patients may also have breakthrough pain? So we revised the literature, and we saw that breakthrough pain, the prevalence of breakthrough pain, may range from 40 to 80% of cancer patients, and in very few studies in the literature, it was reported it may reach up to 74% of non-cancer patients. The problem is that the prevalence variability that we have found depends on the setting when the study is done, and depends above all about the definition that was used to identify breakthrough pain. Because the first definition made by Portnoy and Hagen back in 1989 was talking about something like a transitory exacerbation of pain that occurs on the background of otherwise stable pain in a patient receiving chronic opioid therapy. And the problem with the other definition that the literature were showing during the year is that nobody is really, there's no consensus about how many episodes may be called breakthrough pain, how long they may last. Does the patient has to be on opioids or not? Does he have to be a cancer patient or not? And so on and so forth. So this is what is undermining also the research in this area. So what we did, we took 120 consecutive non-surgical chronic pain patients of our center, and we wanted to see if in these patients what was the prevalence of breakthrough pain, what were the characteristics of these episodes in mixed cancer and non-cancer patients. So what we found was that actually our sample was made of a third cancer patients and 2/3 non-cancer patients. We found breakthrough pain in 55% of our sample, which was a bit less of what was at the time known in the literature. The mean number of episodes a day was around 5, and when we analyzed the characteristics of the episodes, we were a bit embarrassed because we didn't know what to do with the patients, for example, who had their breakthrough pain episodes lasting more than 30 minutes or an hour. Because if a patient has episodes of breakthrough pain that last more than an hour 10 times a day, it means that 10 hours a day he is not covered. So this means it's not breakthrough pain, but it's background pain that is not controlled, actually. So we were we published in the European Journal of Pain our studies, but we were very embarrassed about them because actually when you have this kind of results, you don't know exactly what kind of therapy to deliver to your patient, not to do anything at all, to drown this patient with long-acting opioids, to give him short-acting opioids, or what is called now rapid onset opioids, which are the transmucosal opioids. So the big issues in breakthrough pain diagnosis is that there is no international consensus concerning the definition or classification system of cancer or non-cancer breakthrough pain. The available common assessment tools are not sufficient to identify breakthrough pain. There is no clinically well-validated BTP assessment tool, and even though there are several recommendations on the assessment of breakthrough pain that have been published, none of the tools that are present in the literature cover all this issue. And of course, you know that you cannot treat something if you cannot measure it. So at the time, we were also developing a questionnaire about the classification of chronicity in patients, and we bumped into the issue of prognosis. Prognosis relates to the likelihood or the risk of outcomes in people with a given health condition. apparently it is more useful for formulating clinical issues than pursuing diagnosis, because diagnosis is a dichotomy. It's false or wrong, and it may be misleading for clinical decisions, while prognostic information can influence the patient's outcome and cost effectiveness of care, and it permits also targeting of treatments and making best decisions according to the risk and the likelihood of the problem that you are measuring. So we gather what we know, what we knew about breakthrough pain, the fact that it's quite common, the fact that it has low frequency in the 24 hours, short duration, very intense intensity, and we developed a questionnaire about the breakthrough pain. And we also went through its formal validation. Formal validation means you have to look into its content validity, the construct validity, reliability, and so on and so forth. What is important in our questionnaire, we developed an operational case definition of breakthrough pain. And we said that a patient with breakthrough pain, we said because we looked in the literature and we also based on our experience, we said that a patient with high risk or high likelihood to have breakthrough pain should have, first of all, a prerequisite elements, which means a persistent chronic pain with an average intensity in the past 7 days of NRS less than 4, and around-the-clock strong opioid treatment for this pain, pain exacerbation with an intensity of NRS more than 6, and that this pain exacerbation is not correlated with the opioid administration schedule, which excludes the end-of-dose failure. These were the prerequisite elements. Afterwards, 1 minute? Wow. The clinical discriminant characteristics are the duration and the frequency of these elements. So what happens at the end, that the patient may have potential prerequisite elements to have BTP, but he will have high likelihood to have BTP only if the frequency of this episode is less than 5 a day, and the duration of this episode will be less than 30 or 60 minutes. The patient who have only one of these discriminant elements will have intermediate likelihood to have breakthrough pain. And a patient who has only the prerequisite elements but no discriminant elements has a low risk for breakthrough pain. Clinical implication of this is when you have high risk for breakthrough pain, you will use rapid onset opioids. If you have intermediate risk, you will carefully evaluate the use of rapid onset, and probably you will use short-acting opioids. If you have low risk, you will not use none of these, but you will evaluate the control of your background pain. So this is our 11 items protocol questionnaire. And this is how the questionnaire appeared with our patient that I described you at the beginning of my talk. He had high likelihood for predictable breakthrough pain of known cause. So we done a validation study, and apparently we found in a sample of 120 patients with chronic pain, we found only 44 potential breakthrough pain, which is 36%. If you remember the first study we've done, we found 55%. And among these, only 11 persons had high risk of breakthrough pain and were to be treated with rapid onset opioids. I will finish now because this guy there is going to hit me.
Okay, I do apologize. We do need to move on to the next speaker. You can get with him in lunch here because we are a little behind, folks. We are.
Very important question for him. We could do it maybe when we come back. Okay, now, thank you very much.
Thank you.
Or sleeping, and now half of you are hungry, so it's really a challenge. When I was teaching for 35 years, I actually complained to my department head, why they give me lectures on Monday morning and Friday afternoon when the students are half dead? And the chair told me that if there's one professor that keeps students awake, it'll be you. So I forgot about the complaints, and I was happy with that. Anyway, so my topic today is about prostate health and enlarged prostate. How many of you have done research on prostate, either using allopathic or using naturopathic? Okay, excellent. So we have one person. I've done both. About 15 years ago, I was working with a company in Toronto called Apotax Inc. to develop a drug for prostate cancer, which is called flutamide. It took me about a year. It's very similar in pharmacology to Proscar, but of course with side effects, as I'm sure you understand the pharmacology and toxicology of those drugs. About a year and a half ago, when I was approaching 64, I went to my doctor, and he found that my PSA level was 26. So he suggested you do a biopsy. But since I'm kind of scared about biopsy and so on and some of the side effects, I start to do my own research. What is it that I can do to avoid the biopsy? So I start to look at this herbal ingredients here for this formula, which is actually made from the IPM polymer matrix, which we have done a patent on it. Canadian patent, US patent, and international patent about 10 years ago. And we presented the evidence using diclofenac inside the IPM matrix in an international conference in England, London, England. And we had a lot of inquiries from so many drug companies about using this topical IPM matrix to reduce pain, because the IPM is made from hyaluronic acid, which penetrates the skin, first, second, third epidermis layers, and go to the pain site. And through the NSAID and diclofenac, I'm sure you understand the efficacy of it. It works really well. Also, it is used for diabetic ulcers. People who have diabetes and they have ulcers that does not heal, it helps it to heal. So it's still actually on the market as we speak. A company called Glyco Bioscience, which has the matrix, has the patent on the matrix. So I start to use this matrix, IPM, using the actual herbal ingredients to reduce enlarged prostate. So the first ingredients, I'm sure you've heard about it, which is called turmeric or curcumin, which has lots of publications in the integrative medical literature, how to reduce inflammation, particularly for prostate. And the turmeric and curcumin, 100 milligrams, in the IPM matrix, the efficacy in the delivery system is quite high, because we apply that cream right in the scrotum area, under the testicles and the anal area, so it directly under the prostate, so the efficacy of the delivery system is quite high. The second ingredient is called beta-cytosterols. I'm sure most of you have heard about this one, which is 100 milligrams. Next one is a very commonly used herbal ingredient called saw palmetto, which is used for prostate orally. But when you use saw palmetto orally, you need a lot of massive dosage. But when you have it in the IPM matrix in the cream form, you have very low 75 milligrams, which actually penetrates quite highly. Next, clean from tomato, which is 50 milligrams. Pygam bark, which is 30 milligrams. It's from the bark of the African evergreen tree, Each one of those ingredients have evidence-based efficacy in the integrative medicine literature. And then next one is quercetin, which some of you know as antihistamines, and it actually reduces the inflammation of the prostate. And nettles, 10 milligrams. And the next herb is called Muria poma, 10 milligrams. Next one called Epedium, 10 milligrams, which help with erection for men, because most people with enlarged prostate, they have problem with erection. And vitamin B6, 10 milligrams. And next one is vitamin E, 10 milligrams. And the last one, zinc, which is the most important elements for prostate health, 5 milligrams, zinc sulfate. These are basically all of the ingredients. So we've done this test, 24 subjects over 6 months, and we had improvement of 14% in the reduction of the PSA, and also in the reduction of frequent urination and urgency for urination, particularly during the daytime and also at nighttime. Some men, they wake up twice. Some of them wake 3 times, depending on the age. And now, after using this for 6 months, they maybe wake up once or none. So the improvement was significant. I'm happy to tell you, I was one of the researchers and also one of the patients. I used this myself, and my PSA is half as it was before. So that my urologist told me, you're going to be on active surveillance without biopsy. And I just turned 65 last month. So I'm very grateful with that, and very happy to see those results. Also, earlier in the morning, for those of you who attended my lectures on the biomat, sitting on the biomat also helps a lot. In fact, sitting is now becoming a chronic disease. We sit a lot without moving. I highly recommend somebody with PSA, high PSA, or high BPH to move every 2 hours. If you have a long flight, like 10 hours to go from here from A to B place, every 2 hours, at least every hour and a half, get an aisle seat and just walk around, because sitting for too long, it's not healthy for the prostate. Actually, it's not healthy for any condition. How many of you have heard the research on sitting and chronic health disease, chronic diseases, not just for prostate, for other things like spinal pain and so on and so forth. So that's the results. You're going to find those published results, which was accepted in May 22nd, just like 2 weeks, in my website, academyofwellness.com. And I'll be happy to send you this by email. I'll be happy to answer any questions. And since I did not have time on the first lecture on the biomat, I'll take some questions right now and discussions. If you have any, for those of you who missed my first lecture on the biomat, you have no clue what I'm talking about, come and see me afterwards. We'll give you a session on it, and then we'll talk some more about that. So here I finished before even giving the signal, and then we'll open for questions, which is, goes back to you. Questions, comments, discussions on prostate health. Wow. This is the first lecture ever in my life when nobody have any questions. It's either I made everything crystal clear that I answer all of your questions, or I put you to sleep. Which one? Thank you so much. Thank you, Doc. Dr. Ziad, I really like it. Thank you so much. Okay, any questions at all about this? You're not in natural treatment for BPH? Oh, thank you, Doc. Thank you, Dr. Hal. From a great scholar, that's a great, thank you. Any other comments, discussion, anything else you'd like to talk to me about?
You just apply this transdermally?
Exactly, yes, topically. Only once before bedtime, 15 minutes before bedtime. Mm-hmm. Once. Yeah. Yes, sir, doctor.
Any nutritional suggestions to patients with prostate, besides using the herbal supplement?
We try to avoid lots of fried food. Mm-hmm. I don't want to talk about dairy and all of the hormones and bovine hormones and all of the stuff, but this is something I also recommend, to avoid dairy. And watch the intake of like fried stuff, especially bacon, with nitrite, nitrosamines, all of the things that can exacerbate inflammation. So this is something that I always recommend my clients to do. It's on my website under Wellness IQ. Yes, doctor.
I have a question about cost.
Yes.
What's the relative cost of this cream?
The cost per month for the herbal ingredients is very minimal. The cost for the IPM matrix, because it's patented, is quite, it's approximately $50 per month covered under the plan. in Canada.
Uh-huh,
Yeah,
okay.
$50 per month, including
It's
everything.
reasonable.
It's quite reasonable.
Yeah.
As compared to Proscar, flutamide, yes,
Mhm.
absolutely. Yes.
I see a lot of people exploring curcumin for pain and turmeric.
Yes.
Along with the essential oils.
Yes. Yes.
And I haven't heard very much about that conversation here, and I'm not sure I would expect to, but I'm really interested in hearing more about it from an integrated medicine point of view, because there aren't clinical trials,
Yes.
and so the experience is
I'm
not
so
well
happy
documented.
That you answered, you asked these questions because there's more research done on turmeric, particularly in India, because they use turmeric in their curry food. And the actually thousands of published literature on turmeric and curcumin, not just for prostate, not for just a larger, in fact, for dementia, for cancer. It has anti-cancer properties.
And anti-inflammatory.
And inflammation is one of the best natural I hope some of our allopathic experts here can. I agree with fentanyl. Definitely, I agree with all of the stuff that we use, analgesic and NSAID and Celebrex. All of this stuff is excellent, right? But if you actually incorporate turmeric, you can titrate the dosage to reduce the medications and then increase the herbal, because the efficacy is quite high. The published.
Bioavailability is almost zero.
Okay, the bioavailability. It depends. Okay, it's a good question. It depends on how you administer it. If you put the curcumin in food and cook it at higher temperature, it reduces the bioavailability.
Even if you get 10 grams, it gets into like 100 nanograms in the blood. And 100 nanogram does nothing. In fact, there is...
Yes, exactly.
Yeah.
This is a delivery system. You have to use essential oils to deliver it, or the IPM to deliver it right to the target site. You have the bioavailability increased, and you have the high TI. When you increase the therapeutic index through bioavailability is really the best possible.
Because one of the guys who's done a lot of work is Agarwal, who's in... I mean, he's written a book. In his book, it says that the efficacy is absolutely not proven. I mean,
on the other hand, doctor,
cure from cancer to Alzheimer's disease. That's what people claim. He himself says that efficacy in a therapeutic situation, it's never proven to be anything. Yeah, of course. I mean, prevention if you take of course. That I agree with.
But as our good doctor here was saying, there's actually published literature on curing cancer and relieving inflammation. I agree with you, the bioavailability is low, but if you use the proper delivery system, doctor, you have to understand.
There is no proper delivery system available. Everybody talks about
I just showed you one. This is, okay, this has 3 patents. We can,
of course.
this has 3, it's published, this is published. Like it's,
That's local absorption, I agree with.
okay, excellent.
Taking orally, that's what I
No, orally, you have to use essential oil, as the doctor was saying. Yes, absolutely, because you want to increase the, yes, because of the GI. Yeah, absolutely, HCl. Yeah, absolutely. I agree with that. Yes. Good.
The whole winter, we became yellow.
Yeah, exactly, beta carotene. Any other questions? Any other comments, discussion, advice, or where do we go from here? Yes, doctor.
Is your gel available in the U.S.? Is your gel available in the U.S.?
I just finished the study, doctor. No, it's not available yet. It will be available. It will be through Glyco Bioscience. I'm only the scientist. I have no financial interest in the company. I'm just their scientist. I did the research, and it will be available in the US, Canada, and worldwide. Yeah, but the IPM gel is available worldwide for diabetic ulcer, for topical pain relief. It's available, patented. Yeah. Called the wound gel, IPM, wound gel, Glyco Bioscience. I'm glad I did not put anybody to sleep, and they still actually. It's amazing.
Amazing.
Well, thank.
Yeah.
I said prostate, not. I did not. Thank you all so much. Thank you.
My name is Dr. Doug Spiel. I'm a recovering radiologist. I've been doing chronic pain for about 15 years. Chronic pelvic pain, huge problem in the U.S. Diagnosed with pain greater than 3 months, pelvic pain, 2 weeks per month for 6 months. So it's something that's been around. Roughly 1 in every 7 women in the U.S. between the ages of 18 to 50. We're looking at a number of about 10 to 20 million women in the U.S. Very underreported. Women don't feel comfortable talking about it with their pain docs. They will talk about it with the urologists and the gynecologists. So 10% of all GYN referrals, very high prevalence in patients with depression, sexual abuse history. The medical costs are astronomical, $2.8 billion. Very poorly treated. So if you look at some of the studies, here's a study, 3.5 years, 25% said they were treated effectively. So why it's so difficult to treat? Let's look at some of the etiologies associated with chronic pelvic pain. So at the very top, I put the frequent comers, endometriosis. You'll notice a star and everything with a malignancy. The reason for that, I will treat people who've been under care for cancer. I don't want to treat any concurrent cancers. Ovarian retention, ovarian remnant, these are associated with chronic pelvic pain. I didn't say they're the cause, they're associated. Pelvic congestion, pelvic inflammatory disease, tuberous sclerosis outside the U.S., bladder neoplasm, interstitial cystitis, painful bladder syndrome, radiation cystitis, GI carcinoma of the colon, constipation, inflammatory bowel, and irritable bowel associated. There's abdominal wall complaints, neuralgia of the iliohypogastric, inguinal, and pudendal nerves. Those are big comers. And a couple of others. Some important facts. We're going to take a minute or two on this. So many patients that come in with chronic pelvic pain have no documentable problem, no anatomical derangement that we can focus on. Many have endometriosis, 40-60% concomitant IBS, 80-90% depression, 45% of dyspareunia, they can't have sex. That's 75% in patients with IC. 38 to 85% of IC. Well, how can this be? Here's 38 to 85%. Here's 80%. We're a little bit above 100% already. IC's urinary urgency, frequency, bladder, pelvic pain, the absence of infection. Very important because the hallmark of IC, Hunter's ulcers, seen in only 10% of IC patients, yet they all carry the diagnosis of IC. Pelvic varicose veins, 30%. Dysmenorrhea, very common. Pelvic inflammatory disease, if you've had that, you got a 30%, roughly 1 in 3 chance of having chronic pelvic pain. 65% of these patients have this. Frequent complaints of vulvodynia. 72% of patients from tertiary care centers have more than one diagnosis. Very important. So what does it mean? Well, you can have IBS, you can have endometriosis, pelvic inflammatory disease, you can have IC, you can have 2 of the above, but what is the end product is chronic pelvic pain. So what I want to take you to is a new hypothesis. Just like we're dealing with migraines as though they're CRPS of the brain, we're dealing with CRPS itself, which is a neurological manifestation that takes place after prior injury. I think what we're looking with chronic pelvic pain is no longer an anatomic basis, but rather a neuropathic basis of the pain itself. So I don't care what your initial insult was. I don't care if you had surgery, radiation, endometriosis, IC. I don't care if you have inflammatory bowel disease, as we heard earlier today. The insult's irrelevant. Treat the end result. So I can't really take you through the end result and how to treat it unless you understand a little. So very fast, because we've had some excellent discussions on these. Nociception and pain, sensory afferents are either C fibers or A delta fibers. They synapse on second-order neurons in the spinothalamic tract in the dorsal horn, dorsal root ganglion. There's 3 types of second-order neurons. There's low threshold, high threshold, and wide dynamic range neurons, which get input from multiple different types of nerves, A delta C fibers, which are essentially pain, A betas, and visceral afferents. This convergence of afferents on one neuron helps explain some of the loss of specificity and the referred pain. Then the second-order neurons go north. They cross over the contralateral spinal cord, ascend to the brain. They synapse on third-order neurons in the thalamus and eventually go on to the somatosensory cortex. The somatics have cortical representation. The visceral afferents don't. One of the reasons that we have very poor localization for visceral pain. Then we have a couple of things that try to keep the body in check, homeostasis, if you will. We have descending pathways or inhibitory pathways triggered by CNS cortex, thalamus, periaqueductal gray, nucleus raffi magnus, locus coeruleus. Those stimulate inhibitory neurons in a dorsal horn, and the inhibitory neurons synapse on a primary afferents in the dorsal horn to try to release certain opioids and inhibitory neurotransmitters to turn the pain down. That's the way the body reflects itself and watches itself. Now, we heard a little bit earlier today about some other noxious chemicals that cause wind-up. Chemicals or inflammatory mediators centrally is NMDA. When peripheral nociceptors are stimulated to sufficient intensity, the NMDA receptors in the dorsal horn are generally stimulated, which increase the excitability of some of these other second-order neurons, like the wind-up neurons that we discussed earlier. A brief talk of peripheral sensitization, then I'll take you through central sensitization. Peripheral sensitization, a heightened response to primary afferents. Inflammatory neurotransmitters may sensitize those afferents. That's seen with IE, endometriosis, interstitial cystitis, vulvodynia. You get abnormal or excessive sprouting, and after frequently an initial peripheral nerve injury, there's greater loss of C fibers compared to the larger A beta fibers. So the A beta fibers, they splice into the areas of the dorsal horn that were normally synapsing with the C fibers. As a result, the A beta fibers can take on a nociceptive role. That's one of the ways we explain cutaneous allodynia after viscerosomatic pain referral. A word about sympathetically mediated pain. Just like the non-sympathetic fibers, these fibers can also become upregulated, and they can be sensitized by injury or ongoing neurogenic inflammation. You get abnormal sprouting in the neuromas here as well. The proliferation of sympathetic neurons in the lower reproductive tract of animals is under estrogen control. So estrogen may affect the vulnerability of SMP. I think that's important because among other insults that women have, they have more estrogen than we do. And chronic pelvic pain is about 10 times more frequent in women than men. Central sensitization. Changes in CNS to facilitate, distort, or enhance pain. Wide dynamic range neurons. We talked about activation with NMDA. The visceral afferents, and we're frequently talking about the visceral afferents with chronic pelvic pain, produce more dorsal horn excitability than somatics. We're going to talk about neuroinflammation. Cord, which facilitates central sensitization. That's where one nerve can talk to an adjacent nerve. It's a key mechanism behind the multi-organ involvement of chronic pelvic pain. I like to call that neural cross-sensitization. It's not only my term, it's in the literature. Close connections in the dorsal horn of the spinal cord, and that allows for the neuroinflammation to spread from involved to uninvolved neurons. Once the end terminal of the previously uninvolved afferent is stimulated in the dorsal horn, substance P, among other substances, travels retrograde down C fibers and A delta fibers, leading to sensitization at the terminal nociceptors. They've surgically induced endometriosis in rats, and look, they have interstitial cystitis, neural crosstalk. There's some other systemic effects. We've talked a lot about inflammatory autoimmune syndromes. That's certainly more common in people who have IC, and you see some of the other correlations here. The anatomy of the pelvic nervous system. This is very simple, and there's not a lot of relay stations. We're going to go over them a little bit right here. Superior hypogastric plexus. That receives the sympathetic contributions from the inferior mesenteric ganglion from above, and I'm going to show you diagrams. These sympathetic fibers continue down through the inferior hypogastric. They innervate the lower pelvic structures as well as the vulva. Everything sympathetic comes from above. Some of the parasympathetic innervation arises with the second, third, and fourth sacral segments, contributes to the plexus via a pelvic nerve. Visceral afferents. I just showed you the sympathetics. So above the peritoneal reflection, pelvic structures within the peritoneum have their afferents pass through the superior hypogastric plexus and enter the spinal cord above. Extraperitoneal structures below the peritoneal reflection have their afferents pass through the inferior hypogastric plexus and pelvic splanchnics to enter S2, S3, S4, and the spinal nerve roots, except the very lower vagina and vulva, those visceral afferents pass through the pudendal nerve. I went back and I looked at all the Netter diagrams and the other diagrams when I was doing superior and inferior hypogastric plexus blocks, because I was trying to figure out why the patients were doing better. The recommendations are in the literature for superior gastric plexus blocks, but it didn't make sense until I looked at some of the pictures. So this green is the perineum. Here's the uterus. Here's some of the lower structures in the vulva. If you look here, here's the ovaries, uterus. These are intraperitoneal. The red are sympathetics, superior hypogastric plexus here, inferior hypogastric plexus here and here, pelvic splanchnic nerves. This is pudendal nerve here and here. The blacks are the afferents. You'll notice that the peritoneal reflection here, the sympathetics, the reds, go all the way down from the superior ganglion through the inferior ganglion, all the way down to the periphery. So sympathetically mediated pain, we could stop right here. The afferents, on the other hand, above the peritoneal reflection, they seem to follow the superior epigastric plexus. Below that, they follow out the inferior plexus, out the splanchnic nerves, and down very below, if you're dealing just with vulva pain that's afferent-related pain, you'll see the black afferent fibers going with the pudendal nerve. The innervation of the urinary bladder, some of the urination of the upper bladder, some of the sympathetics, do go through the superior hypogastric plexus. In fact, much of it does. You'll notice that some of the afferents below, they'll go with the inferior hypogastric plexus. And when you get down very, very low, these black afferents, these fibers go with the pudendal nerve. We talked a little bit about irritable bowel earlier today, and that's important, irritable bowel as well. Now, we talked about neural crosstalk in the central spine, but I want to show you something. These sympathetics that go from the inferior hypogastric, from the superior to the inferior, travel on right to the distal rectum here. And there's also afferent fibers coming through there that go through inferior hypogastric plexus. So this is just a diagram showing the superior hypogastric plexus, left and right hypogastric nerves, inferior hypogastric plexus here. Here's S2, 3, and 4. Pudendal is right down here. From in front, again, superior hypogastric plexus, which is about L5, S1, very easy to reach via needle. Inferior hypogastric plexus, about S2, 3, also easy to reach with a needle. And this is just a lateral view showing some more of the diagram. So what other medical condition begins with an insult and leads to severe chronic regional pain? CRPS, right? Complex regional pain syndrome. So CRPS has some signs and symptoms. They have sensory symptoms, hyperesthesia, allodynia. They have vasomotor symptoms, temperature, skin color. Pseudomotor symptoms, edema and sweating, motor and trophic changes, decreased range of motion, weakness, tremor, dystonia, hair, skin, nail changes. Now, some of these aren't present in the pelvis, but some of these really are. The allodynia, well, some of these women have such bad vulvodynia they can't even put in a tampon. Pelvic varicosities, I said, were prevalent in 30%. Why isn't that just some of the symptoms? And finally, we're talking about motor and trophic changes. If you look at pelvic floor muscle dysfunction, that's about 85% of patients with IC. So what we're really looking at is CRPS of the pelvis. CRPS comes in two flavors, sympathetically mediated pain and sympathetically independent pain. A word about anesthetic block. We do an anesthetic block when you come to the ER and you have a cut, and we put a little lidocaine in. That lidocaine works for about 2 or 3 hours, and it wears home, and we got to give you something for the pain. But if we do a chronic pain patient, we do a sympathetic block. Many of those patients feel good for days or weeks or longer. Why? Because we're taking advantage of the neuroplasticity of the nervous system. If you turn it down, sometimes it takes a while to kick back on. Sequential blocks are one of the mainstays of sympathetically mediated pain in the literature. The problem has been, to date, we couldn't do long-term blockade because none of the catheters would hold. So this is the protocol I use for female chronic pelvic pain. Superior hypogastric plexus block, if that works, I can do a couple of blocks. If it doesn't work, or if I want to get to a more long-lasting block, I can place a catheter. This superior hypogastric plexus block takes care of the sympathetically mediated pain of most of the pelvic structures and sympathetically independent pain of the structures above the peritoneal reflection. If the SHP block doesn't work, the inferior hypogastric plexus block will work almost all the time. This works way more than is necessary to do this. And I think that is because there's far more sympathetically mediated pain than sympathetically independent pain when we work along the pelvic viscera. Again, inferior hypogastric plexus block, if that works, I can do repeated blocks or I can use an indwelling catheter. That'll block the SMP, sympathetic mediated pain of some bladder and rectum, and the sympathetically independent pain of some structures. And finally, if we go down to pudendal block, that'll block the sympathetically independent pain of the very peripheral structures. Again, this is just a picture of the superior hypogastric plexus block. It's not a good one. 2 needles at L5S1, a little bit of dye right in front of the sacral promontory coming to the distal L5. It sits right about here. 10 cc's on either side of bupivacaine, 0.25, with or without epinephrine. Here's the catheter I'm using. This is an IntelliCath, it's an intelligent catheter. It's trademarked as well as patent penned. It's got an indwelling core. Tines hold it in place once deployed through a 12-gauge needle. You can tie it in a knot. It'll still infuse. That's what it looks like. How much time do I have? Okay, so we're going to go through patient presentation. Maybe we'll move on to med. Very good. So I'm going to show you 2 different types of patients that I've treated and why their presentation, their treatments have been a little bit different. Patient AK is 28, endometriosis 15 years, multiple laps, multiple laparotomies, bladder biopsy, perforation, septic shock, MVA. Here's her symptoms: burning pelvic pain, dysuria, vulvodynia, dyspareunia, dysmenorrhea, frequency, urgency. Here's her prior treatments. We got the opioids in here. We got some antidepressants. We got some other pills here. So the current treatment, when I initially blocked her, I do a superior hypogastric plexus block. And this is directly from my notes. 100% initial response, 48 hours. Well, that's longer than the duration of the anesthetic. And I don't have the catheter in my ability to use for another 6 weeks or so. So these are sequential blocks that I'm presenting here. So go out a week, do another one, another week. So now we've done 3 in about a 3-week period. 100% relief for 4 days. Goes out another 3 weeks. Pain remains improved, limited pelvic pain, abdominal pain, dysuria, despite menses. So I've had over a month here with a couple of blocks. Again, for another 2 weeks, I do a superior hypogastric plexus block, dyspareunia, dysuria. Incidentally, this woman flies up from Florida so that she can have sex with her husband. Superior hypogastric plexus block again. Follow-up. Now, here's another problem. Menses every 10 days, severe bleeding, severe dysuria. Still on oral contraception. I've noticed that a lot of these women do better outside of estrogen. If you take the estrogen off, their pain goes down. And we said that estrogen increases sympathetic tone. Follow up, the menses stopped. Look, pain significantly better, near 100%. So with the current trauma, her pain gets worse. And she's been followed up, pain a week, menses. Follow up again, severe menses, severe pain. So if you continue to have trauma, so here she gets a D&C. She's had the concurrent insult of these traumatic events. She gets a D&C and now she's better again. She stays better, moves to Florida. Persistent pain relief, vulvodynia, dyspareunia, some abdominal cramping, ovulation, menses. She has another GYN surgery, and I would expect her pain to get worse again because they haven't fixed the internal problem yet. Let's compare her to somebody else. All right, so here she is in March of 15, pretty much 80% across the board here. This was good for a couple of months and then dropped to 30%, the vulvodynia and dyspareunia. She does very well. This is just with sequential blocks. Take-home point, treat the ongoing anatomic pathology, address the hormonal dysregulation. Separate patient. This patient started, remember I said it didn't matter what the initial insult was. Treat the end problem. She starts with 5 to 6 IVF treatments. Bladder pain, pelvic cramps, urethral burning, dysuria, urgency, frequency, difficulty ambulating, sitting, vulvodynia, dyspareunia, pelvic floor spasms. She's got everything, right? She's had a couple of treatments, used a couple more. No cystoscopy, doesn't want bladder distension. She heard that makes it worse. Refused progesterone, maybe intelligently. Her block, 1 week later, 65%. Second block, 4 weeks, 80 to 85% improvement. Third block, 70% improvement. Now, I've followed her out past here, and I'm getting a couple of months on every one of the blocks. Maybe we have 5 minutes for men, huh? All right. Men are a little bit different. Prostaglandin, we talked about that a little bit earlier. Chronic pelvic pain, unexplained pain in men. Associations in men. Urinary tract, urinary obstruction, interstitial cystitis, inflammatory bowel constipation. We've seen some of these before. Colon cancer, abdominal wall dysfunction. We've seen the pudendal and ilioinguinal hypogastric neuralgia. Epididymitis. We've seen a couple of these, and some of them are specific to men. And some of the prior treatments they may have undergone. Ultrasound, urinalysis, alpha blockers, we talked earlier about that. Cystoscopy, hydrodistension. So here's the take-home points for men. Most common urologic diagnosis in men over 50 is chronic prostatitis. Third most common urologic diagnosis in men less than 50. So I said the other were 10 to 20 million women. These are 2 million visits in the U.S. by men. What's important, you know, the urinary pathogens are rare. So if you look at chronic prostatitis abacterial, about 10% of these have a recoverable organism. So only a third show signs of inflammation after biopsy. And you're biopsying the angry ones to begin with. So they have a panpelvic hypersensitivity syndrome, no different than women. Voiding problems, pain in the pelvis, pain on sex, pain in the genitalia, pain in starting the streams, feeling of fullness, painful ejaculation, they got everything. Again, IBS, IC, chronic prostatitis, interstitial cystitis, and chronic prostatitis. What's the take home? Still chronic pelvic pain, right, guys? What's the big one? Chronic non-bacterial prostatitis. So NIH has all kinds of fancy diagrams for this and scoring regimens, and they can take you through this or that. Innervation's a little bit different for men real quickly. You'll notice that the testes and epididymis go separately than the other pelvic organs. So nerves from the testes and epididymis, they follow the lesser splanchnics. You can do a lesser splanchnic block there. The penis, there's sympathetic input coming from superior hypogastric plexus all the way down. Bladder, we talked on before. Prostate, some of the sympathetics start from above, superior hypogastric. Some of the other ones come directly through the inferior hypogastric. So male chronic pelvic pain, a little bit different than a female. So for testes and epididymis symptoms, if those prevalent, you're going to start with a lesser splanchnic block. If that works, drop a catheter. You can do this around T11, T12. Penile symptoms, I would recommend you start with the inferior hypogastric plexus because of the nerve network and the way that plays out. Again, if it doesn't work, you can go down a pudendal block. And finally, bladder and prostate symptoms, I want you to manage this just like women. Start with the superior hypogastric plexus block, go to an inferior hypogastric plexus block if that doesn't work, and you can repeat both of these with the IntelliCath. I think we have a bright future looking ahead. Thank you so much. We have time for a question or two.
Yes. Anybody? Anybody have a question?
I think they're hungry.
I think they're hungry. Okay.
Sure.
Okay.
So with corticina, you have a couple of different problems. So with corticina, you have a central sensitization frequently because you have a central neurologic injury. We say central because the cord is just, it's a lower motor neuron lesion, but it's proximity to the upper motor neurons just above that. So with corticina, you can have a combination of upper and lower motor neuron injury depending upon where you clip it. If you clip it below the termination of the cord, it'll be straight lower motor neuron. If you go a little bit higher, you get a little bit of both. With that, you do get a lot of pelvic problems. Some of those problems are due to damage to some of the nerves themselves. So it's not just the pain you're dealing with. You're dealing with incontinence and difficulty both on urination and defecation, secondary to injury to those nerves. This may take away the pain. I don't think this will restore the function.
I got a couple of people after this meningitis outbreak, men, who are experiencing both autopoietic and something that looks like this, without any help.
So with the meningitis, this is mostly related, obviously, to epidural infection, and some of these people have an intrathecal infection. So again, once you've cleared that, I don't care what the insult was. If you're dealing with pain, this is one of the ways to ameliorate the pain. And we know that by blocking pain peripherally can lead to central changes based on functional brain MRIs. So just because you're doing a sympathetic block or even a somatic block in some cases, you may still see changes all the way up above once you get to the third order neurons.
And the local anesthesia, the duration of action in all these cases when you infiltrate the local anesthesia is much longer than what you see on a...
Correct. So what you're dealing with here is, and I showed, where if we go back here,
So you're talking about decreased sensitization.
I'm talking about plasticity. You're taking advantage of the way the body works. If you hit something a couple of times, you can essentially turn it down. So imagine the sympathetic nervous system in many ways is like the amp on your body's stereo of pain. A sympathetic block in people who have some pain that's sympathetically mediated turns it down a little bit, but not for a really long period of time. So what we do sequential blocks. And then people will tell you, well, if the sequential blocks don't work, you got to move on to neuromodulation, you got to do intrathecal pumps. No, you need to find a better way to place the block. So the longer the blocks are, the better the chance of taking advantage of the body's neuroplasticity. So if you do a block for 7 to 10 days, that's kind of the sweet spot at turning it down. And then the body's normal homeostasis kicks in, you pull the cath and you're done.
But how would you see sympatholytics, for example?
So people have done sympathectomies in the past. There's something known as Caisson's rule of hypersensitivity. What does it mean? If you ligate the nerves to your iris, you will get lack of sympathetic tone, and you'll get pinpoint pupils. But after a couple of weeks, the circulating catecholamines will affect the end organs, and your iris will open wide. So when you do sympathectomy, they used to do it for arterial foot ulcers. By the way, you can use the IntelliCath for that. They used to use it, and what happened was 4 to 6 weeks later, it stops working. It stops working because you've effectively damaged the system. You've upregulated your peripheral systemic receptors. I'm not killing anything. I take it out, normal just goes back. Question? So the question is an excellent one. So I'll be preparing to do a study this year. So I'll have the catheter to my disposal within the next 6 or 8 weeks. I hope to do hundreds, and with the help of other docs, if not thousands of patients, before we eventually get FDA approved. And the question is a simple one. It's a good one. How do I compare the catheter-based treatment with neurostimulation and similar things? We have pelvic stimulation. We use spinal cord stim as well. The question is an important one. If you're a patient, would you rather me put something in for 7 to 10 days, or do you want to walk around with a generator for the rest of your life and get no MRIs? I think all of us in this room would rather have a 7 to 10 day treatment. Just like we'd rather treat things anatomically if there's an anatomical problem before we go on to chronic pain management with neuromodulation. I think it's a good one, and I really hope that my studies play out after the next year and shows significant resolution of symptoms that many patients don't go on to need the neuromodulation. I use them too, and spinal cord stimulators certainly still have a place in everyone's practice.
Okay, all right.
All right, thank you very much.
Okay, welcome to the afternoon session. We're going to continue our pain conference here. Right now we have an interesting talk on P2X7R activation, which will be presented by Dr. Romulo Jose Suarez Bezerra.
Thank you. Firstly, I want to thank you for this opportunity to show my work and get some opinions and some feedbacks. Then the presentations was made. I work in the Fiocruz in Rio de Janeiro, Brazil, and this work was of my PhD thesis, and our aim was to find new molecules or compounds with action, the inflammatory and nociceptive signaling through the P2X7 activation. The P2X7 is a part of the purinergic receptors, which they are subdivided into two groups. One group is named P1 receptors that are activated by adenosine. They are subdivided into 4 types. And we have the P2 receptors that are activated by nucleotides. They are subdivided into 2 classes. One are the P2Y that are coupled to a J protein. They are 8 types. And we have the P2X receptors. There are 7 types. They are ionotropic. They form a cationic channel in the cell membrane. Into this group, we have the P2X7 that is my aim. And the expression of this receptor, they are widely expressed in many cell types, and as microglia, astrocytes, monocytes, macrophages, lymphocytes, and other cells. And in regard to its activation, he is activated by ATP, that is your physiological agonist. When he is activated by extracellular ATP, which can be delivered from the other cells in process like necrosis, the ATP intracellular comes through to the extracellular medium and activated this receptor. They open a channel, a cationic channel in the cell membrane, which allows the passage of cations. So when this receptor is activated by high concentrations of ATP, like above 100 micromolar, they form a pore in the membrane, which is allow the passage of molecules up to 900 Daltons. But it's also we don't know if its pore is the channel that formed the spore, or if it is another protein couplet. When activated, the P2X7 receptors stimulate various immune cascades like inflammation activation, caspase activation, cytokine secretions, phospholipase secretions, MAP kinase activation, cell death, and others as immunosilins. For this receptor has a pro-inflammatory profile and also a pro-nociceptive profile. For these functions, this receptor is widely researched, widely studied in many disease process like neuropathic pain, rheumatoid arthritis, neurodegenerative disease, and chronic inflammation. What many researchers since that this receptor is an important therapeutic target. Our aim, as I said, was to identify new compounds from natural products that may be candidates for potential antagonists to P2X7 receptor. Because there are, as I showed, there are many inflammatory and pro-inflammatory and nociceptive disease related to the activation of this receptor. Then an antagonist could be inhibit this receptor, leading to inhibition on these symptoms. And I used a method that which is already published in the PLOS-ONE. Using this method, I accessed a natural products library, which is an institutional library in Fiocruz. And they have compounds collected in the whole world. There are fungi, there are bacteria, there are plants, extract of plants. And I tested 1,800 compounds. They has 12,000 compounds in this library. And I found only 3 compounds with such action. And we made the determination of the inhibitory concentration using cells derived from murine and cells, human cells. And we noted that the compound was more potent in human cells. The other compound has the same activity, here in murine cells, here in human cells. They are more powerful on human cells. And the third compound, and we studied, we also analyzed the action of such compounds on pathways related to the activation of this receptor, like the release of IL-1 beta, that is pro-inflammatory cytokine. And as we can see, the ATP activates the receptor. We have the release of IL-1 beta. But the 3 compounds found by us was able to inhibit the release of this cytokine through the activation of this receptor. Here in murine cells, here in human cells. The same pattern was observed. We also evaluate another pathway related to the activation of this receptor, which is the nitric oxide release. We use the GRIS method, And as we can see, LPS, ATP, the compounds in the presence of ATP, they inhibit the release of this inflammatory modulator. And as the same pattern was observed using human cells, we had another question. Okay, these compounds inhibit IL-1 beta, the release of nitric oxide, and the reactive oxygen species that is also related to the activation of this receptor. As we can see, these compounds was also effective in the inhibition of the release of reactive oxygen species. We also evaluate the cytotoxicity of these compounds when we treat these cells with the IC50 concentration of each compound through 24 hours, and we noted that these compounds were not cytotoxic. And to complete our characterization, we also evaluated electrophysiologic experiments, which are very, very important to find a molecule which has some specificity to this receptor. And this method is better to characterize the action of some compounds on this receptor. And as we can see, the compounds also in electrophysiologic experiments inhibited the activation or the formation of currents. We passed to the in vivo experiments, and we assessed a protocol of neuropathic and inflammatory pain using the formalin, which is a compound that evoked a pain. We treat the mice with the compounds, these as morphine, diclofenac, BBG, which is the antagonist of this receptor, and these are the compounds. And we noted that the treatment with the compounds as with the antagonists for its receptor was effective, which seems to be action related to inhibition of the activity of this receptor. Oh, sorry, I forgot to tell you that this receptor is already identified in the dorsal horn. And in the time of 0 to 5 minutes, we see this result. And in the time of pain, the three compounds were active to inhibit this receptor. Now we are under the next step, which we requested the patent of these compounds in Brazil, and we are evaluating the characterization of the molecules responsible for such activities. Here, as we can see, are several compounds also related in the literature that was tested into many pain contexts as rheumatoid arthritis, inflammatory pain, and in preclinical phases, clinical phases, and until now, no one passed. And in the context of natural compounds, some molecules were found with such activity, but all they are under preclinical phase, which turns very important our research. And we are trying to strengthen our collaboration with other institutes and companies to give a segment in our research. And thank you. Thank you. Any questions? Rio de Janeiro, where I live. Yes, I can't tell you because the patent process, but I will. It's a fungi product. I was very, very impressed when I discovered that such compounds were from fungi, like cyclosporine and other medications that actually is used. They were from fungi.
All right, any other more questions? Nope.
Thank you.
All right, I get to give the next talk. I'm Jim Adams. I'm from the University of Southern California. That's in Los Angeles. And I have a PhD in pharmacology. I also have been working with the Chumash Indians of California for many years. I was a student of a Chumash Indian healer for 14 years, and when she passed away, of the Chumash people asked me to become the healer to the Chumash people. So I do two things now. And I'm going to talk to you about how the Chumash people approach pain, which is completely different than what you might expect. And I hope you read my quote here on the bottom, because if you don't understand that that's intuitively true, then I can stop right here. So the skin, we've learned in the last 14 years or so that the skin is the major pain sensing organ in the body. And the skin has 27 or 28 of these transient receptor potential cation channels in it. It's kind of an array that scares people, because people think we can't deal with that many pain channels all in the skin. So people want to simplify things, and that's the way we approach pain treatment. But that's not the way the Chumash people approach pain treatment. So these transient receptor potential cation channels are part of a pain cycle that starts in the skin, goes to the brain stem, then the brain, and then comes back out to the skin. And they are, when you activate this pain channel, you can magnify pain greatly. So we're only now learning how to catch up with the Chumash and how they treat pain. Here's another view of the pain cycle showing you the cycle. On the right over there is the descending neuron that goes back into the skin and is a neurotrophin releasing neuron. So they're all activated by a bunch of different things that we know about, and a lot of things that we're still in the process of discovering. The other interesting thing that we've learned about pain, chronic pain, is it involves the induction of cyclooxygenase 2 in the skin. It's not clear to me how that happens, but it's been very clear to me with several patients now that it definitely does happen. And when we give oral medications, you know, the NSAIDs, the Celebrex, to block cyclooxygenase 2, it doesn't work in the skin. They don't get into the skin in high enough amounts to be effective. And in fact, what people like Ma and Kirion have started doing is injecting cyclooxygenase 2 inhibitors into the skin. Well, eventually we're going to figure out how the Chumash people do it, and I think it's so much better. So we insist on using oral medications to treat pain because we insist that we have to treat pain in the brain and the brain stem. We think it's the simplest way to do it. And the Chumash people have a different approach. So currently we're causing 100,000 ulcers a year from oral NSAIDs. $50,000 per ulcer, $5 billion in this country we pay to treat those ulcers. 10,000 of those ulcers die, which to me is very scary. You know, these are people who are treating mild to moderate pain with NSAIDs, and they die from their ulcers. It doesn't seem like a good trade-off to me. These NSAIDs also cause kidney pathology, increase blood pressure. Acetaminophen causes liver pathology. And all of these NSAIDs also increase strokes and heart attacks, because what they're doing is they're throwing off the balance of prostaglandins and thromboxanes in the body. And that balance of those eicosanoids is so delicate, and we don't understand it. We don't know why we're causing all these strokes and heart attacks with these NSAIDs. So again, we're treating mild to moderate pain, and we're killing people with strokes and heart attacks. We also use opioids a lot, and I used to be the medical editor for House MD, the television show. So about every couple of months, I'd tell the writers, "You've killed House MD from a Vicodin overdose. He's dead." We insist on giving oral opioids to our patients, oxycodone and hydrocodone especially. And we have what I call the carpenter approach. If the hammer doesn't work, get a bigger hammer. So you start out with a little bit of Vicodin, and then before you know it, you're up to fentanyl patches and oxycodone and oral fentanyl. And, they cause addiction tolerance. They also cause opioid hyperalgesia. I don't think anyone has mentioned that yet today. Once you've been on these opioids long enough, they increase pain. They don't decrease it. And 14,000 people every year die from these prescription opioids. And they cause respiratory depression and seizures. The seizures are especially caused in infants and children with these opioids, something that we don't take into account as much as we should, in my opinion. So since we insist on giving oral medications to treat pain, we kill patients. That's not the Chumash way of treating pain. Chumash people don't like to kill people with their drugs. So we also have some topical medicines that no one has even talked about these topical medicines so far at this conference. Camphor, cineol, menthol. You can buy, I think it's an 8 or a 10% menthol liniment that you can use. You've got all these things that various basketball stars are advertising on the television that you put on for your pain. And these are inadequate because they only treat a few of those transient receptor potential cation channels. And the thing I didn't mention with the transient receptor potential cation channels, they're located on the C fibers and the A delta fibers in the skin, those afferents, but they don't overlap. So there are populations of those neurons that contain the transient receptor potential cation channel V1, the vanilloid one. There are other populations that contain the TRPA receptors and the M receptors. So the populations don't overlap. So if you give something that specifically inhibits the TRPV1 receptor, you've still got all those neurons that are active that contain the TRPA1 receptor or the TRPM1 receptor. So you're only getting rid of a small fraction of the pain by using these compounds. So here's California sagebrush, Artemisia californica. And my teacher taught me how to make a liniment from this plant. And when she first taught me, she told me, well, you use it for broken bones, you use it for when people fall off a cliff and hurt themselves. She taught me it's used for severe pain, not mild to moderate pain, severe pain. And I really had a question about that. I kept saying, gee, how can a liniment that you just put on your skin work in severe pain? Well, we just heard a talk from Brazil. The one thing that I've learned in working with California plants is that we know a lot more about those plants in the Amazon than we know about plants in California. This plant right here, which is an abundant California plant, we didn't know anything about the chemistry of this plant until I started investigating it a few years ago. And I found that it contains these monoterpenoids. With a French pharmacy student who came to my lab. So there are 15 of them: camphene, menthidine, beta-pinene, eucalyptol. Eucalyptol is a very potent pain reliever. And you notice these are all monoterpenoids, 10 carbon units. So they all very quickly penetrate the skin. No problem getting across the skin. Camphor, some of these compounds, we don't know what their pharmacological activities are in TRPV receptor activation. Here's some of the other ones. thugenone, all of these, borneol. We don't know the activities of many of these compounds, but they're all present in this liniment that my teacher taught me to make. So some of these, we know that some of these inhibit the TRPV1, vanilloid 1 receptor. We know that some of them inhibit the TRPA1 receptor. We know that some of them inhibit the TRPM3 receptor. So there's quite a bit of inhibition, activation, and then deactivation of these transient receptor potential cation channels. And it's not just one or two, it's a whole host of these transient receptor potential cation channels are being inhibited by these 15 different compounds. And that's very important because if you want to inhibit pain, you have to deal with the whole population of all those receptor potential cation channels. Some of these are also, they decrease the expression of COX-2 in the skin. Present in this liniment are also these sesquiterpenes, and sesquiterpenes are 15 carbon compounds. So leucidin is known to inhibit COX-2 and to decrease the expression of COX-2. Echinolactone probably does the same thing. The other ones we don't know the pharmacology of these compounds. Now, if I was a Chinese pharmacologist, I'd be working night and day on these, and I'd probably have all the answers for you already, and I'd be able to tell you, I've isolated, a kilogram of pestylodiopside, and I know what it does. But, in this country, it's different. We have a different approach here. Maybe not a better approach. So, here's the recipe. I don't have a patent on it. This is owned by the Chumash people. This comes from the ancestors. And so what you do is you take 86 grams of the leaves and stems of the plant and 1 leaf of white sage, which enhances everything, and 1 seed of avocado because you get some oil from that. And then you put it in isopropanol for 6 weeks. And in the old days, they didn't use rubbing alcohol, they used whale oil or bear grease. I can't use those things anymore. Maybe somebody from Tennessee could give me bear grease, I don't know. I doubt it.
We have a few.
Do you? We have a lot in California too, we can't touch them. They can touch us, but anyway. So you leave this in a glass jar for 6 weeks, and then you get this beautiful green liniment. And I started using it since I am a healer. I'm protected by California state law because I practice traditional healing in California. I didn't bring any of this liniment with me here. I'm not protected by Chicago law. I'm only protected by California law. And believe me, I gave a talk similar to this one time in California. And there was a lady sitting over here in the audience. She let me know that she was from the FDA, there to make sure I was doing things right. So I've treated more than a couple hundred patients at this point with this liniment, and my teacher had treated, probably several thousand in her lifetime, plus her grandparents had treated several thousand. So basically, it's very easy to use. What happens is a patient will come to me and they'll say, I hurt here. And I say, great. Take a cotton ball, get it wet with the liniment, put it there, rub it on. That's it. In 10 to 20 minutes, the pain is gone. Sometimes a patient will say, I hurt here. They'll put the liniment on, and then they'll say, I've discovered I actually hurt here too. Okay, put it there too. Okay, it's not easy. Osteoarthritis, rheumatoid arthritis, chronic back pain. So with chronic back pain, what I have them do is I have them painted on their lower back, the whole back. And at the same time, I tell them to decrease their opioids by 1/2. And next week, decrease by another half, then another half, until they're finally off the opioids. and they don't need them anymore. And then I want them to start a program of gentle exercise, walking, swimming. Where's our physical therapist? She's gone. Anyway, some sort of gentle exercise, enjoyable exercise, because that helps you unlearn your pain. Chronic pain is a learned experience. You learn the pain, the cyclooxygenase 2 levels go up in your skin as part of that learning process. You have to unlearn your pain. Fibromyalgia, I've had several women who say, I hurt here, here, and here, and I say, great, put it here, here, and here. Broken bones. Did I just say broken bones? I did. I've used it to treat broken bones. My own wife fell down and broke her patella in half. Her doctor gave her Vicodin. Guess what that did for her? She vomited all over the inside of my car. Didn't help her with her pain. I put the liniment on her knee. In 10 minutes, her pain went from 10 to 3 for a broken bone. Her pain come back 3 hours later. I put it on again. Her pain went from 7 to 1. I've treated car accidents, bicycle accidents, cancer pain. I had one woman who had breast cancer that had metastasized to her lungs. She was in so much pain she couldn't sleep at all. So I had her daughter put it on her chest, and it helped her pain go from 10 to 5, which was enough to at least help her sleep. Now she had terminal cancer, and she died a couple weeks later, but at least she was able to sleep. Neuralgia, I've treated diabetic neuropathy, AIDS neuropathy, shingles. The only one that hasn't responded is the one guy who had AIDS neuropathy. He said it didn't work for him. I've treated overexertion. I'm a runner. I run 8 miles, including this morning. I've run 23 marathons. I use this stuff in myself every time I overexert myself, which is almost daily. But anyway, I've used it for bursitis, kidney stones, gallstones. Gosh, you know, anytime a patient comes to me with severe pain, this is what I put on them. I say, can you point to a place where you hurt? Okay, put it there. That's the way I treat their pain, you know? Gallstones, where do you hurt? Here. Okay, put it there. You know? It's that easy. Funding is not available. I've tried to do clinical trials with this liniment in California. I actually even have a pain clinic that wants to run clinical trials with me. I wrote the application for the investigational new drug, and the FDA did not approve my application. They want more toxicity testing with this traditional medicine that has been used in thousands of patients. But I cannot get funding from the NIH to do the toxicity testing that's required by the FDA. So I'm stuck. I can't, I have to use it only inside of California as a traditional therapy. I can't take it outside of California. Don't tell anybody, but I brought some to my father in Michigan last summer because he had a hip replacement, and that was more than 10 years ago. And his hip replacement is starting to fail now, so I've given him some of the liniment to treat his hip. But that's where I am at this point. And I think we need to learn how to treat pain in the skin. I really do. It's so much easier, it's so much safer. Did I just say safer? It's so much safer than what we're doing. And I think we need to learn from the Chumash Indians. Why have I learned from the Chumash Indians? I'll tell you, because I know someone is going to ask me. My family came to this country in 1635. My first ancestor who came here was William Adams, who was a surgeon. His job was to keep the Puritan community in Virginia alive. So he learned right away. He couldn't wait for the medical from England. He learned healing from the Indians. My family has always used American Indian healing ever since 1635. American Indians have kept my family alive. That's why I'm here today. Thank you for coming to my talk. I'm ready for some questions.
Any of the individual compounds, you've tried all these several channels?
No. No, I can't get any funding to do anything. I'm not like you. I don't know how you get your fund. Well, you don't work on plant medicines, that's why.
Yeah, I mean, resinoprotoxin, it's NIH, you write a grant.
Yeah, see, I write a grant and the NIH says no. It's that simple, you know? I have 240 publications. I'm 61 years old, and the NIH won't give me funding. That's life. Welcome to America. Huh? Yeah.
Excuse me?
There has to be a reason. Anyway. Yes.
Okay, thank you so much for this nice talk. I would like to ask you about regarding the duration of action, for how long does it work and how frequent per day, or the other thing is, the other question is there any reported side effect like skin allergies or anything from your patient to this medication?
So it depends on the pain. My wife with her broken knee, the first application lasted 3 or 4 hours, and after that she didn't need it. The second application she didn't need anymore. She went to naproxen after that. Most patients, like the arthritis, rheumatoid arthritis and osteoarthritis, they use it once a day in the morning when they get up. The one guy who had injured his shoulder and hip in a bicycle accident, he used it at night before he went to bed to help him sleep. I don't know if you've ever had road rash. It's really hard to sleep when you have a big scab on you. The lady with cancer pain, she used it once a night before she went to sleep. So most people are using it once or twice a day for their chronic pain. The back pain people, I had a pharmacy student who couldn't sit in class because her back hurt so much. So what I had her do was paint it on her back in the morning before lecture, and of course she had to sit through 4 to 6 hours of lecture every day. And then I had her put it on again at lunchtime, and she said, you know, she was what was it, 6 Vicodin a day I think she was on, which I told her was the toxic dose. And then she went down to 0 Vicodin within a month and a half, 6 weeks. She was down to 0 Vicodin and off the Vicodin. And well, she was only using the liniment. And then she started the walking routine as well, gentle walking, enjoyable walking with her husband and her daughter. And I'm pretty sure she's off the liniment now too. So she's doing really well. I've had several back pain patients like her, chronic back pain. Usually once or twice a day.
Okay, any other further questions?
Is this the only material that is being used in this way, or is there a family of products that you're using with this approach?
So there are several pain medicines that the Chumash people use. I'm only presenting one today. I could present several others. This one is for the most severe pain. There are others that work really well for less severe pain. And maybe I'll present them at future talks.
Have you done any, like HPLC?
I've done, of course, HPLC, mass spec, and all that.
Do you find that there's variability from year to year with the
Any plant, there will be variability from year to year, especially in California, from drought to rain and back and forth again. You know, it's a real problem in California.
Or does it have a problem with functionality?
No, in fact, this liniment is amazing. When you need it, you make it and you use it, and it works. In fact, there is one pain medication that in a severe drought, the plant dies and you can't use it when the plant is dead. But The number one problem that we're having is that most of these California plants have never been examined to find out the chemicals in them, none of them. As I said, we know more about the plants in the Amazon than we know about plants in California. So welcome to the United States. All right, let's move on.
All right. Thank you very much, Mr. Chairman, ladies and gentlemen. My name is Fahid Muhabbati, and I'm a specialist pain physician and also a palliative medicine physician from Sydney, Australia. I do lecture at the University of Sydney and also work at the Royal Prince Alfred Hospital and Liverpool Hospital in Sydney. Obviously, from the title of my presentation, I'm going to update you all on what's going on with the pain and palliative medicine in the Middle East. So I thought probably I need to give you a bit of demographic on the Middle East. I'm sure that not everybody is interested in geography, but thought probably mentioning where's the Middle East, how many countries, depends on who you ask. Some say 17, some say 12. They include parts of North Africa, including the Egypt, into that larger group. But most of the countries that I'm referring to are those 12 ones that are actually around the Persian Gulf. A huge number of people live in there, and the rate of growth in terms of population is also very rapid compared to, for example, India or China. The rates is almost twice as high. The two most populous countries in this region, Iran and Egypt, have a population which is higher than those of Italy, UK, and France. So, large number of people live there. There's the ratio of the young people, the population is generally pretty young compared to other parts of the world, including United States and Europe. And there's a large gender differences in their population structure. Unfortunately, life expectancy at birth is a lot lower compared to the western side of the world. Non-communicable diseases still are the major cause of deaths in most of these countries. There are major demographic, economic, and political differences across all the countries from the Middle East as well. So, why Middle East? Why did I, or why was I interested, in the Middle East? I do have an interest in the epidemiological studies, and I do like to study particularly prevalence of different types of pain. So I started to look around to see where the gaps are, and did try to do a literature search, and what I found was quite interesting. We looked at the number of papers that were published with the term pain or chronic pain in their title or content, particularly in Iran, and all we could find was 226 papers from 1946. Of those, only 95 used chronic pain or persistent pain. Most of them looked at small subgroups of pain. When I did a literature search for the term palliative care, it was even worse, only 8 papers. So a huge problem in terms of recognition of the problem and the lack of the services in the area. One of the other imperatives that sort of got us to do the study on the prevalence of chronic pain was the lack of availability of prescription opioids. Perhaps people don't know that in the United States, in the West, there's a huge problem with the use of, or overuse of, or misuse of prescription opioids. Whereas in 83% of, or 83% of the rest of the world, there's a huge lack of prescription opioids. I'm not quite sure if this is a good thing or a bad thing with the new sort of literature, and also Adam's talk that increase in use of this prescription medication causing increased deaths. There's also lack of awareness of societal and individual impacts of pain amongst health professionals and general public as well. So the aim of our study was an initial assessment of chronic pain in a community sample of which is a city in south part of Iran. It's the 5th most populous city in Iran with a population of around 2 million people. We did a cross-sectional population-based survey. A study was conducted in 114 postal zones of Shiraz in spring 2012. We based our study on a European study which was done by Breivik and his colleagues titled Survey of Chronic Pain in Europe, Prevalence, Impact on Daily Life and Treatment. They conducted this study in 15 European countries and Israel. We used a multi-stage stratified cluster method, dividing Shiraz in 2 districts, and then selecting districts randomly into blocks, and finally dwellings on the blocks were selected randomly. We conducted a face-to-face interview, screened people, and calculated the minimum sample size to be at least 1,000 participants, again based on that European study. Indeed, we studied 1,050, 50 more than what we needed. Inclusion criteria for the study was age greater than 18. They needed to be residents of the city of Shiraz and to have chronic pain for at least 6 months. And the frequency of pain had to be more than at least twice weekly. The only major exclusion criteria was having serious psychiatric illness for obvious reason, and also developmental disabilities due to limitations in terms of interview. So of that 1,050 people, 767 did not have pain. 283 people responded, and they went into the second stage of the interview. The questionnaire that we used was based on the questionnaire that the Breivik and his colleagues used, and 63 questions, 14 primarily sort of questions, and then to the next stage, more in-depth questions about the type of the pain. Here are some of the demographics of the study. interestingly, probably similar to other studies, we found that chronic pain is more common in the older group. There was female-to-male preponderance in favor of a female group, but we didn't find significantly or statistically significant differences in terms of their education or occupation. We found that only 6.95% had chronic pain. This is, although this is significant, but it's significantly lower than what it is in most of the Western countries. Of those with chronic pain, almost 83% were under some form of treatment. The longest duration of chronic pain at the time of the interview were 7 months and 20 years, respectively. The median of this was 24 months, with an interquartile range of 12 to 48 months. 19% of them had constant pain, and 78% had intermittent pain. In terms of severity, 81% had moderate pain, 19% reported severe pain, which we considered on a score of above 8 on a numerical rating scale. 47% were house spouses, 18% were employed full-time, 12% employed part-time, and 12% were retired, and 11% unemployed. Almost half of them with chronic pain reported that chronic pain had impacted on their employment status. I mentioned the prevalence of pain in favor of female gender. But as mentioned before, no statistically significant findings on marital status, age, education, or employment status, no correlation with chronic pain. Of different types of pain that we studied, musculoskeletal pain was on the top, gastrointestinal pain second, and headache or head pain came third, which was also a bit surprising. Headache wasn't as common as we thought it would be. And less than 1% mentioned cancer as the cause for their pain. In terms of what they used pharmacotherapy. The most commonly used analgesics were NSAIDs, narcotic analgesics second. They used beta blockers, don't know why. COX-2 inhibitors only in 3%, and muscle relaxants also in 3%. 37% used non-pharmacological treatment, and the most common techniques included traditional cultural medicine, which is similar to the type of CAM, complementary and alternative medicine in the West, acupuncture, thermotherapy, exercise, and massage. So this table shows the different types of non-pharmacological treatment that were used. Coming to satisfaction with treatment, up to 50% of participants were satisfied with their treatments. Of those, 44% reported very high degree of satisfaction. 93% reported they complied with their doctors. They took their medication religiously. And pain was reported to be under control by almost 80% of the participants as well. Looking at the wider literature, a report by Ospina and Horstel, the average prevalence of chronic pain reported to be 35%. WHO estimates that 20% of the global population had some degree of chronic pain at any given period of time. In other countries, America 25%, European countries 20%, Norway had the highest with 30%, Spain with lowest with 12% in Europe. In an Australian study, it was reported to be 18.5%, and Canada with 10%. So it's quite variable. And in another report by WHO, it says could be between 5 to 30%. So it sits within that range. The interesting bit was that the rate of satisfaction with treatment in our cohort was much higher. They used less non-pharmacological treatments compared to their European counterparts. But the use of analgesics and almost similar drugs, except for some of the less available opioids. For example, oral opioids not that easily available. The only form of the prescription opioid that is available is fentanyl patch, the Duragesic, which is exclusively used for the cancer pain. We had limitations in our study. We thought about doing sort of a pilot study because this was a first of its kind in the region. So we did not really investigate the different types of pain, comparing neuropathic versus nociceptive versus inflammatory pain. We appreciate that we had trouble capturing all pain populations, particularly those with cognitive impairment, dementia, nursing home residents, and so forth. We put the duration of the pain 6 months in our study, and we're aware that some studies used shorter period of time to define chronic pain, like 3 months, or in some 2 months was used. So these could also have some effects on our findings as well. And the timing of the interview, because interviews were sort of done during the daytime, often people who stay at home, the ones that actually don't work, or they're sort of in housewives and elderly people who are retired. What we thought that doing face-to-face interviews are a strength of this study compared to most other studies which are done over the phone or computer-based. So to conclude, almost 7% prevalence rate was significant, as mentioned. But surprising, given that Iran has been through many turmoils in the past 30 or 40 years with the war, 8 years war, many natural disasters, including floods, and also very high number of road tolls. Almost 22,000 people die every year from car accidents, which is incredible. Given that those survive probably reach to almost 1 million mark. And you would expect that some of them would have some sort of pain due to those accidents. Okay. We sort of thought to do, the same sort of a study on availability of the services coming into the pain and palliative services. We looked at the atlas of the global atlas of palliative care, which was recently published by WHO, and they actually used pain as the indicator of availability and access to palliative services in the world. Just looking at the time. Pain and palliative medicine does not exist as a service. There are some practitioners that actually do work, do look after some of the palliative patients, but there's no such service as palliative care in Iran. Pain services are also new. It's a new specialty, as I realized. They started to train patients, mostly anesthetists, but it's mostly interventionally driven. There's no sort of multidisciplinary type pain practice as such. I looked at some of the literature in terms of the importance of pain relief and also providing palliative services. Cousins and his colleagues argued that access to pain relief is a universal and fundamental human right, and same was argued about the palliative care by Frank Brennan. In underdeveloped world, which is most of the world, apart from the North America, Europe, and Australia, access to these services are quite rare and patchy. There's a need for collaborative effort in positioning pain and palliative services, hiring global and national health agendas, and there's a need for clear policies establishing pain and palliative care, use of educational programs to improve teaching pain and palliative medicine, to improve access to essential medications needed to deliver pain and palliative care, and also improve organized service delivery programs in both services. And I'd like to finish my talk by a poem from Saadi, which is one of the great Persian poets from the 13th century. He says, and this is actually written on the UN's entrance, human beings are members of a whole in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you've no sympathy for human pain, the name of human you cannot retain. Thank you. Questions if we have time.
Do we have any questions?
Any questions? Okay, there's one.
How many people are dying of cancer in Shiraz a year?
Well, we don't know the exact data, but there are reports that there's a tsunami of cancers coming in Middle East, particularly in Iran, and factors involved in this, including change in their lifestyle, environment pollutions, and so forth. So there's no real report on...
I was asking that because 6% of the population with chronic pain is very, very low.
It is very low.
Very, very low.
Yeah.
We have a battle for palliative care going on in the U.S. for people who do not have cancer, but who remain at home without support. Can you speak to that as a palliative care specialist about what might be going on around the world on that issue?
Well, I can talk about our Australia. I work as a palliative physician 2 days a week and pain physician 3 days a week. The system over there is actually pretty good in terms of the support in the community. But it's still, it's not perfect and it's not ideal. There's always room for improvement, and it comes down to the health economy and the money. And we've been noticing more and more cuts to the budgets in terms of providing those services. In the United States, to the extent that I know, it could be quite patchy, and depends on where states you live. Some states, it's pretty good in terms of the community support, but in some, it's not up to the standard that it should be.
Does the palliative care group, I mean, is there sort of a theory of this evolving in terms of how it should be defined and delivered?
There is. There are working groups from the WHO. There's also the International Hospice and Palliative Care Organization. There are also localized organizations within America and also in most of the Western countries looking at developments of the services in palliative medicine. So things are improving, but I think it's an under-recognized issue, particularly when it comes to non-malignant conditions. We are more and more aware of non-communicable disease, non-malignant conditions who need palliative support, including the HIV/AIDS patients, motor neuron disease, chronic respiratory and cardiological conditions such as heart failure. And these people are in need of palliative care, so it's not just the oncological patients.
Also among the oncology patients, nobody knows if you have to start palliative care upstream or downstream. So the palliatives themselves, they don't know that. So it's a question of money.
True.
Well, I also kind of feel like it's a question of model. If we're defining chronic care, chronic pain is 90 days or more. You know, what's the threshold for moving into a palliative care program? From what I can observe, it's at 90 days. You know, you can prevent an awful lot of harm by starting with the right kind of care early. And not waiting until it's just unrecoverable. With so much suffering.
That's a problem. I think we need policies and also educating, particularly health professionals. There is a stigma with the name of palliative care. Unfortunately, we don't have any alternative for the use, but both consumers and also health professionals are avoiding palliative care because of its negative connotations.
So we define it as hospice care. And so there's a huge gap between 90 days and the hospice, unless somebody's standing there with a gun to their head. I just think it's untenable
Mm-hmm.
when we're dealing with this issue that we haven't addressed that gap.
I totally agree. Okay.
The other thing you have to keep in mind is that in this country, we're spending 18% of our gross national product on health care. 18%. We're far above anyone else. Australia, Italy, we're far above anyone else. And it's not because our health care is any better than anybody else's. It's just because we recognize that we're a lot sicker than most other people.
Well, we're also waiting till the end of days and then having to deliver the highest cost health care.
Yeah, we choose the highest cost first. Yeah, you know, if you've got a problem with your heart, why not just get a heart transplant?
Well, my time is run up.
Yes, thank you. My name is Wolfgang Stelzer. Thank you to Omics Group for the invitation and for the opportunity to speak here about our Austrian experience. I'm an anesthesiologist and founded a outdoor pain center for mostly radiofrequency therapies, pain therapies, interventional pain therapies. We are strictly following the guidelines from the International Spine Intervention Society. And yes, here is our experience. The influence of BMI and gender on pain degrees and medication usage of the medial branch neurotomy, the conventional neurotomy, and after treatment of the SI joint. I haven't found a lot of data about BMI, and I haven't found a lot of data about the influence of gender, and so that's for me as an interventional pain therapy, it's most important to know what we do, and I want to know what this means, what we have done. And this study was designed to illustrate the general outcome after radiofrequency after 1, 6, and 12 months after treatment. And the outcomes were stratified by BMI, gender, and age to determine the effect on the reduction of opioids and NSAIDs as well. We had 164 patients with chronic low back pain who underwent the treatment. These records with the chronic low back pain were selected. First, we had some inclusion criteria for the treatment. It had to be a low back pain longer than 6 months. And we have to have a pain relief for more than 50% after singular lumbar medial branch block or intra-articulary SI joint block. The VAS or NRS pain scores from 0 to 10, the quality of life, the BMI, medication usage, and satisfaction with the pain management were collected. As I said before, at 1 month post-procedure, again after 6 and 12 months. The techniques were the International Spine Intervention Society suggested technique with the parallel needle technique on the medial branches. And the technique of SI joint is cooled radio frequency technique of the rami posterioris and the L5 dorsal ramus with a cooled radio frequency that a bit colder than the 80 degrees from the conventional. It's about 60 degrees, and each lesion you have to do for 2 minutes and 30 seconds. The degrees are degrees Celsius, of course. So the inclusion criteria for our treatments, we make a lot of pain therapies, and one of our what we are specialized tool is the radio frequency therapies, and the inclusion criteria for these therapies are the chronic low back pain has to be longer than 6 months. The VAS pain score should be greater than or equal to 6 in this 6 months. The pain should be localized here in the facet joint region or SI joint region. So we should have signs and symptoms of these pain regions during the physical examination. Also, previous failure to achieve adequate improvement with conservative and non-invasive treatments, and received more than 50% pain relief from a single medial branch or SI joint block. Here is the whole sample. It's interesting. The 130 cases, 161 cases after 1 month, I can explain it. Here is the statistics. The Kolmogorov-Smirnov test and Shapiro test were the tests we wanted to find out, to compare these two treatment options. Also the non-parametric Wilcoxon test, and all analyses were performed using the SPSS version 22. Total, we treated 857 patients during the time from September 12 to June 14, and all patients were sent a questionnaire with a self-addressed return envelope, and after 6 months and 12 months we got back 193 forms. That's about 22.5%. So there were 29 with exclusion criteria. Some patients had filled out the form or had other health problems like surgery interventions also. 31 had some missing data, and 31, and that's the little bit complicated table from the last slide. We had 131 completely filled out forms. An interesting point, during all procedures, during all 857 procedures, we couldn't see any severe or moderate complications. The results in the total group, that means lumbar and SI joint mixed, of course, because of the statistical analysis, we could see that we can compare it. VAS degrees of 4 points from 10-point scale from 8 to 4 was demonstrated in 6 months and to 4.5 after 12 months. The lower medication usage was demonstrated with degrees in opioids by 40% and NSAIDs by 60% anyhow. Decrease in reported pain was shown for at least 12 months. The data illustrates significant better outcomes for patients with an BMI lower than 30 and no gender-specific difference in decrease in VAS. But here's the bar. As we see, the blue box is a 6-month group in the total group, and the red box are the 12-month group, nearly the same about 8 VAS on the scale, dropped down after 1 month to 4.3, 6-month group, 4.1 in the 12-month group, and dropped down to 4, 6 months, and 4.5 in the 12-month group. Here are the bars from the medication usage. As we said, opioids, green bar less, and same the blue one. And we had a total 64.7% less medication than before the treatment. Here's the table where we see lumbar and SI joint mixed or split it up. So we see the mean. Is there any laser pointer here? Yes. Thank you. Okay, here is the mean lumbar 6-month group. We started about 8, dropped down after 6 months to 3, 8 dropped down after 12 months to 4.8, and SI joint 6-month group we started about 8.2, dropped down to 4.6, and after 12 months to 4.5. The BMI dependence, I think it's an interesting point that starting at the same level from VAS, we wanted to split the group from BMI 30 we told normal, and more than 30 obese group, and we see that the normal group drops down to 4, and the obese group to more than 5. And it's also the quality of life that we asked. Do you feel better, same or worse? You can see that more in the normal group feel better, are feeling better now after the treatment, more than 70%, and less than 60% in the obese group. An interesting point also seems to be the confidence interval. The confidence interval, that does mean the 25% probability you have after treatment to get a pain decrease about 3 to 4 points. A good deal to have such options. And the last point is the influence of sex, gender. In an analysis of VAS, we could see that also starting at the same level, VAS about 8, dropping down to 4.4 in the male and 4.2 in the female group, nearly the same. But, and that's an interesting point, I don't know if it's only in Austria or it's a worldwide phenomenon, that the satisfaction with the quality of life, be it better, equal or worse, there is higher satisfaction in the female group. So let's come to the conclusions. The durability of pain relief reported in this study is consistent with other studies. The decreases in chronic pain and medication usage may suggest the use of RF treatment in case of low back pain as a proper treatment option, as well as the probability of 95% to have a VAS decrease of 3 to 4 points on the NRS scale. Limitations are clear, all the limitations that retrospective studies have. No control group to account for confounders such as a placebo effect, but the results are much more better than the placebo effect. The difficulty of a small percentage of subjects to fill out the questionnaire and return it to the investigative staff, and missing data for some subjects is also a limitation. The results of lumbar medial branch neurotomy with a parallel needle technique seems to be as good as the SI joint mediated low back pain treatment option with a cooled RF. It's now from Heliard Health Company. And overall, we have determined that treatment with RF methods for patients with chronic low back pain should be a safe, durable, effective, long-term pain and analgesic reduction treatment option. And we hope that the public insurances can be motivated to provide for reimbursement as a safe and reliable method for the treatment of low back pain. Thank you.
Excellent. Are there any questions? Well, I'll start out. Do you consider obesity to be an inflammatory condition that causes pain?
Pardon?
Do you consider obesity to be an
Inflammatory
condition that causes pain?
I don't know. I think there are a lot of reasons why obesity cause or obese people seem to be more or have more pain. One of the reasons we know that movement and as runner you have better conditions not to get chronic pain, and your pain level seems to be deeper. I think the movement, the physical training is one thing, one reason. Inflammation is also discussed, yes. And but I don't know.
All right.
I don't know.
Question over here?
Just an answer to the question. There has been documented evidence that inflammation correlated with pain, people who have obesity have higher CRP, insulin resistance, clearly published in the medical literature. The answer is absolutely yes.
I agree, and you can read the 4 books that I wrote on that subject.
This is wonderful.
By the way, I've been a runner for 34 years. I don't have any arthritis.
Wonderful.
I've run 23 marathons.
Wow. Any more questions? Okay. Wonderful.
Okay, good.
Thank you. Thank you.
Okay.
Good afternoon, everyone. And first of all, I'd like to say thank you to, how do we pronounce it, OMSIS, for organising this meeting. My name is Dr. Richard Call, and I'm an interventional pain physician, and I'm based in the United States. And the presentation I'm going to give today really is, it's going to be through a video, and it's about the Spine Africa project. And it's a charity that I established back in 2008. And it was after a trip to the Democratic Republic of the Congo that the charity came about. And what the charity provides is healthcare services, particularly to patients who've had spinal injuries, education to the healthcare professionals in the Democratic Republic of the Congo, and it assists in administering positive social changes. So I'm going to play the video, and then I'll be taking questions after the video. So could we turn the lights down, please? Is there volume on this? Is there any volume on that?
Can you hear it?
Can you hear it? The Spine Africa project, it really started about 2.5 Can we turn the overhead lights years off? ago. A good friend of mine, she was opening up a school in the Congo, and she asked me if I would be interested in going out and helping in a general humanitarian way. Whilst I was out there, I was in Lubumbashi, which is the capital of one of the provinces in the south called Katanga, and there's a huge mining industry out there. And whilst I was there, I was able to have a tour of a couple of the local clinics and hospitals there. And as I was going around these clinics, I kept coming across young males who had been injured in mining accidents and who had been left with severe spinal injuries or, in some cases, paralyzed. And it occurred to me that there was really no provision for spine surgical services out in the Congo. And this was the seed of the Spine Africa project. My desire at that time was to try and develop a spine surgical service that would be able to achieve a, one of them being education of the local doctors and the local healthcare community in terms of how to treat and manage spine injuries. The second thing was to actually start a foundation that would be able to provide doctors and healthcare professionals who had expertise already in the management of these conditions to go out and treat patients. When we were in the Congo, there were two places that we saw patients. The first place was at the Panzi Clinic, which is in Bukavu in the eastern Congo. And the clinic is directed by a very inspirational doctor called Dr. Denis Mukwege. And the clinic has for years specialized and provided care to women who have been victims of sexual violence. And one of the things that they did every morning, which was really moving, was that they gathered everybody in the courtyard and they had a singing choir that would perform every morning as a source of inspiration and strength for these women who had been through extremely traumatic psychosocial experiences.
été créé en 1999. Et dans sa vision première, c'était venir en aide aux femmes à conditions obstétricales difficiles. Mais avec l'évolution, l'hôpital de Panzi s'occupe aujourd'hui en grande partie des victimes de violences sexuelles. L'hôpital de Panzi, comme je viens de le dire, aujourd'hui ne soigne pas que les femmes victimes de violences sexuelles. Il est vrai que parmi les victimes de violences sexuelles, on observe également beaucoup de femmes qui présentent la pathologie de la colonne vertébrale et qui ont besoin d'une prise en charge spécifique. Il y a des compétences pour ça. La deuxième chose, on voit une augmentation en fait d'autres malades qui ne sont pas forcément victimes de violences sexuelles, qui ont besoin d'une prise en charge de traitement au niveau de la colonne lombaire. Et malheureusement, comme je viens de dire, on n'a ni le moyen diagnostique, ni le moyen de traiter ces malades. La seule possibilité, c'est les envoyer très très loin. Et beaucoup n'ont pas le moyen de pouvoir y aller. Voilà pourquoi c'est très important de pouvoir développer en fait cette prise en charge du traitement de la pathologie de la colonne vertébrale au niveau de l'hôpital de Panzi.
And one of our main goals with the Spine Africa project is to try and raise funds to be able to purchase equipment, to purchase materials, and to bring in radiological imaging devices that are going to allow us to more effectively help the population out there who have sustained spinal injuries and have chronic degenerative spinal conditions.
En fait, je pense que ce que nous avons observé, c'est que il est vrai que les femmes, non seulement elles sont violées, mais ce sont les femmes qui portent aussi tous les lourds fardeaux, je dirais, de la société. Que ce soit dans l'agriculture, à partir de la cultiver, transporter les récoltes, aller vendre les récoltes. Et les femmes font tout ce travail sur le dos. Et parfois, les femmes transportent le poids qui dépasse leur propre poids. Elles commencent à transporter ça au bas âge. Ça, c'est quelque chose qu'on observe. Mais aujourd'hui, avec même le phénomène en fait, d'esclavage des femmes, les femmes dans les mines, elles travaillent très très dur. Elles transportent, elles doivent transporter, par exemple, toute la terre qu'il faut aller traiter sur la tête. Et tout ça, ça comprime la colonne vertébrale et à la fin, ça crée des lésions de compression qui sont des lésions graves au niveau de la colonne vertébrale, ce qui fait que nous avons des femmes qui ont des douleurs extrêmes à un certain âge et ne savent plus bouger, ne savent plus marcher. Et donc, il est très très important de pouvoir faire face à ces phénomènes en leur donnant une vie correcte par les interventions chirurgicales que je pense que Spine Africa peut nous aider à faire.
The civil war in Rwanda was like a tidal wave. It was a tsunami. It had immediate and very far-reaching socio-economic consequences, and the displacement and the killing of a very high number of the male working force has meant that a lot of the manual labor has now fallen literally on the backs of the women. And one of the big problems that we saw when we were out in the Congo was this issue of women from a very young age, and we saw girls as young as 5, 6 years old, having to carry packs from their villages into the town, packs of wood, packs of coal, and some of these loads were up to 200 pounds. And they wake up at 4, 5 in the morning and they set off and they'll walk for 3, 4 hours so they can take their goods to market to sell them. And obviously doing this every day has a very destructive impact on the spine. And what we saw in the clinic there was a high incidence of prematurely degenerated spines, where we had women in their 20s and 30s coming into the clinic, and the x-rays, it was almost as if you were looking at the spine of a 60 or 70-year-old. And the pain and disability that this causes was indescribable.
Je prends à partir du moment où l'hôpital des Panzi, aujourd'hui, c'est un hôpital qui est de référence pour presque toute la région, et que les malades qui viennent, ils viennent de partout. Ils viennent avec l'espoir de trouver des solutions. Malheureusement, nous avons des problèmes diagnostiques. Au niveau matériel, par exemple, l'hôpital de Panzi n'a pas la possibilité de faire les scanners, n'a pas la possibilité de faire les RMI, n'a pas la possibilité de pouvoir en fait mener un diagnostic correctement pour savoir comment opérer. Et je pense que ça c'est la première chose. Nous avons besoin d'un équipement diagnostique pour pouvoir en fait faire le diagnostic correct. Et une fois que le diagnostic est posé, la deuxième étape, c'est d'avoir des capacités de ressources humaines pour pouvoir faire les interventions chirurgicales dans les conditions optimales. Et là, nous faisons un appel à toutes les bonnes volontés de pouvoir nous aider à l'hôpital de Panzi d'acquérir ces équipements. Et nous pensons qu'avec la coopération, nous pouvons obtenir la possibilité d'avoir des ressources humaines pour développer ce type de chirurgie ou de traitement pour les malades. Oui, je pense qu'on ne s'habitue jamais à la souffrance. Et je pense que lorsque vous regardez dans les yeux d'une femme qui souffre puisque la nature est méchante, qui souffre puisqu'elle n'a pas pu être protégée comme elle devrait l'être, qui souffre puisqu'il y a une méchanceté humaine. Je pense que cette souffrance, on ne peut pas s'y habituer. C'est quelque chose qui est tous les jours nouveau et qui fait tous les jours mal. Et je crois qu'au contraire, plus on voit des victimes, plus ça fait mal et plus on a envie de réagir, puisque je crois qu'il y a des choses qu'on ne devrait pas voir. Si l'homme pouvait traiter l'autre comme il voudrait qu'il lui-même soit traité.
The Spine Africa project also wants to raise awareness of the problems, of the socio-economic problems that have developed there as a consequence of the civil war and the continuation of conflict. And we want to provide funds and raise monies to be able to provide, at least in the hospital or the clinics where we're working, a regular source of power and a more reliable source of water. And every member of the family, as soon as they are able to walk, become involved in providing water and food and economic resources so that the family can eat and drink. And we would often see small children as young as 3, 4, 5 years old every day having to walk to the well many, many miles to collect water for the family. The international aid organizations that we happen to meet whilst we're out there are involved in efforts to bring more accessible water outlets to the villages and communities. And the quality of the roads has deteriorated. Certain areas around the immediate cities and towns are tarmacked and allow for a relative degree of convenient travel. As one moves 3, 4, 5 kilometers from the town centre, the roads become dirt tracks, and obviously this has made the delivery of healthcare very difficult. And specifically with regards to spinal injuries and the young guys that are injured in the mines, transporting these guys from the mines to the clinics or to the healthcare facilities is extremely difficult. And in treating these conditions effectively, time is a critical element. The waiter at the hostel that we were staying at had a nephew, 11-year-old nephew, who had a very tragic story.
Okay, so I go to another case which is more connected to plastic surgery, but the reason for me talking about the charity is it brings together what we do as doctors into the realm of politics and social awareness. And sometimes when we're in our private practices, we forget the value of the knowledge that we have. And I think it's important that, you know, in whatever way we as individual physicians can, that we look at these global issues to try and help. So I'm open for questions.
All right, are there any questions for the speaker?
What are they looking for? Are they looking for I mean, he said a lot of things. They need money, they need support, but do they need people also to help there? I mean,
Yes, to all of the above.
All of the above.
Yeah, I mean, it's a very complicated situation, and the immediate steps towards helping to rectify it are exactly those. People with expertise, doctors, nurses, ancillary staff, money, and most importantly, actually, is the raising of awareness so that people around the world know about this problem and, you know, help in whatever way they can.
where is it exactly located?
The Democratic Republic of the Congo. It's one of the largest, well, actually, it is the largest Central African state.
This is what used to be Uganda before?
No.
That's different.
Yeah, it used to be the Congo, actually. It was the Belgian Congo. It was a part of the Belgian Empire.
So I think they mentioned they need generators for electricity. They mentioned, didn't I push it? I think they mentioned generators, NMR, you know, CT scanners, typical stuff that anyone would use here.
You set up an account for that, or how did you do that?
Yes, yeah, it was, the charity was set up in the United States. It was set up as what's a 501c3 US-based charity. And it's into that the donations are made.
Anybody else with a question?
Disaster rehabilitation is a discipline within my profession, and it's a discipline worldwide because of trauma and natural disaster and so forth. And it provides an avenue to take trainees into the field who are learning and have expertise.
Yeah, that's a very good point, Tony. That's one of the things actually that I talked about towards the end of this video clip was or are the educational opportunities for doctors, for example, in America, who don't see this type of pathology in the volume that that it occurs in this part of the world. And it's an interesting paradox and an irony that, you know, the most developed countries in the world are not coming up, the doctors are not having the exposure to the amount of pathology that they should.
That's what we do in part, so, you know, if I can help, I'm happy to.
Thank you. Thank you.
Anything else?
All right, thank you very much.